A very good morning to everyone. On behalf of the entire organizing team, I extend a very warm welcome to all of you to the Scientific Extravaganza, the third edition of the International Conference of Craniofacial Pathology and Biology. I am Dr. Abhilasha, Professor of the Department of Oral Pathology, and it's an honor to be the MC of this event. Before we start with the formal proceedings, I would like to take a moment to introduce this conference to all of you. This conference is an incredible platform that brings together experts, professionals, and researchers from all over the world to discuss and share insights on cutting-edge technologies, developments in craniofacial pathology and biomaterials. The success of the previous edition of this conference has been nothing short of remarkable. The renowned speakers delivering invaluable knowledge and paving way for innovations in craniofacial research and interactions and collaborations for the past years has laid a strong foundation for even greater achievements for this year. As we embark on this third edition, we are thrilled to present an exceptional lineup of eminent speakers who will be sharing their expertise in various domains of dentistry, craniofacial pathology, and advances in biomaterials. We eagerly anticipate a series of lectures that will inspire us with new ideas, foster professional growth, and open doors to exciting opportunities for all of us. So now we will begin. Now I request the dignitaries to please come on to the dais. Dr. Ashwani Kumar sir, the Pro Vice Chancellor sir, Dr. Shija ma'am, Registrar ma'am, Dr. Arvind Kumar sir, the Dean of Saveetha Dental College, Dr. Vinay Hazare sir, our guest of honor, Dr. Nadeem sir, the President-elect of IAOMP, Thank you. Now we will begin the formal proceedings with the invocation of the Tamil goddess, followed by the lighting of the Kuttuvilakku to seek the divine blessings for the success of today's event. Thank you. Now I invite Dr. Pratibha Ramani ma'am, the Professor and Head of Oral Pathology, our organizing chair, a senior teacher and an ardent researcher to deliver the welcome address.
A very good morning to one and all present here. I think it's a proud privilege for me to welcome each one of you to this wonderful and a different sort of a conference which we are having today. At the onset, I would like to bestow my thanks to the Almighty and all the Gurus who have made this day possible. The first and foremost, we are deeply indebted to our Chancellor. He was about to come, but he has had a VVIP appointment, and so he was not able to come in the last minute. And it's all because of his grace and his visionary thinking that what Saveetha is today. And of course, by his visionary son, Dr. Deepak Nalasamy, the Pro-Chancellor, he is the one who has made whatever Sir's dreams as reality, and we stand as #1 college in the country. So heartfelt welcome. Though they are not here, it is always customary that we welcome those who are done this for us. So on behalf of all the organizing committee, it's my proud privilege to welcome Professor Ashwini Kumar, who is the Pro Vice Chancellor of our university. He is a very ardent researcher, and it's our great honor to have him here in this gathering as a part of this research community. Thank you so much, sir. We also welcome our registrar ma'am, our ever smiling Dr. Shija Varghese ma'am. Ma'am is the backbone for all our conferences or whatever endeavors we have. She is very meticulous, she is very systematic, and so we are able to do things in order, because of which we are able to have so many things possible because of for our university. Thank you so much, ma'am. Welcome, ma'am. We welcome our very smart and ever charming Dean, Dr. Arvind Kumar. He is a source of inspiration, and really he helps us with any sort of small problems also. He is there telling us with a smiling face, yeah, this can be done, don't worry. So we welcome you, sir. It's also a great honor to welcome Professor Dr. Vinay Hazare, sir. He is one of the stalwarts in the field of oral pathology, and he has done pioneering work. What we are doing now is what his team has done from 1970s. They have been the people who have laid the basic work in oral submucous fibrosis and cancer research in India, and I am very proud to say, and most of the young generation here, that he has worked with most of the people whom we have read in textbooks today. We read in textbooks today. So we are really honored, and on behalf of our university, we are very honored to welcome you to our university, sir. A special note of welcome to our President-elect, Dr. Nadeem Jeddi. He is more than a friend, and it's like always, he's a part and parcel of whatever we organize in Saveetha, and really happy to welcome you, Dr. Nadeem. It's also my proud privilege to welcome my teachers who are here. 3 of my teachers who are very much present here. Dr. Ramesh sir, who is former Dean of Mahatma Gandhi Dental College and Hospital. Dr. Ranganathan sir, again, he is one of the pioneers in the field of oral pathology as far as Tamil Nadu is concerned. And of course, our author of Schaefer, Dr. Shivapada Sundaram sir, SBS sir, is very much here, and we are really proud to have and welcome the 3 most giants in the field of our field. Thank you so much, sir. It's also my proud privilege to welcome Dr. Jayanta sir, who has come all the way from Kolkata. Dr. Anand Ramanathan, who has come from Malaysia, is going to conduct the Oral Detect workshop. We heartily welcome Dr. Punya, a professor from KLE Dental College and Hospitals. We also welcome our team from Sri Chittirai Tirunal Institute of Sciences, because I think that team is the backbone, or the material science part of it is going to be entirely covered by them. All over India, we know that you have been doing the Make in India is actually done by Sri Chittirai Tirunal, and we are really honored to have the guests from Sri Chittirai Tirunal Institute, and of course Dr. Samindeep and Dr. Mukesh Doble, who are also part and parcel of this conference. Apart from that, we have so many heads like Dr. Shamla ma'am, Dr. Shivakumar sir, and I can see so many of my colleagues here. We welcome each one of you, and students from various institutions. I would like to personally thank and welcome the deans and the various HODs who have allowed them here to be a part of this conference, and welcome each one of you because you are the backbone and the success of this conference. Thank you one and all for all this. And one important thing of this conference is going to be the oral submucous fibrosis symposium. This consensus meeting actually was the brainchild of our Pro-Chancellor Dr. Deepak Nalaswamy. He has been telling me this for the past 5 years, and I'm really proud and honored to have the best of the best in oral submucous fibrosis to take this along, and the vision of my teacher Dr. T.R. Saraswati, who has also worked hard in this particular field. Thank you and welcome each one of you here. Thank you.
So apart from those who are present here, there are also other people whom we like to welcome. Dr. Tilakaratne sir, who is going to be a speaker, and the most senior person in oral pathology, Dr. Daftari sir. Also we welcome you sir for this conference. They will be watching us online. Thank you. And now I would like to request Dr. Sheeja Verghese ma'am to kindly come onto the stage and offer her felicitations. Ma'am has been a key pillar in managing academic administration and also has played a vital role in maintaining the institution's academic excellence. Her leadership and dedication are truly commendable. Ma'am, few words.
Good morning, respected dignitaries on the dais, off the dais, senior faculty members, and the delegates. I'm honored to stand before you this wonderful conference organized by our oral pathology and oral biology department. And third time they are consecutively doing this. First of all, I congratulate our team for organizing such a wonderful conference. And as far as Saveetha, oral pathology department is unique in that we have a separate oral biology department. That basically we have started because we want research to be happened and a translation research has to happen. For that purpose, we have separated an oral biology department, and that is doing wonderfully well, and lot of research translation is happening from that work. Both the department together, they are doing a lot of work. And this conference, especially as Dr. Pratibha mentioned, this consensus, because from the beginning we were, Saveetha was very much on the evidence-based dentistry. Because our undergraduate training as well as the postgraduate training is very much focused on the evidence-based dentistry, and that now with all over, they are bringing the experts from all over the world, and they are doing a consensus meeting on the submucous fibrosis. Definitely that will improve because that is a problem especially in South India and even in North India, that submucous fibrosis is a problem, and I think this consensus meeting will give definitely some points which you can improve the quality of life of the patients. And and all the delegates, please, you can learn a lot of things from this, and I wish all the success for this program. Thank you.
Thank you very much, ma'am. Now, Dr. Arvind Kumar sir, our Dean sir, has been instrumental in shaping the academic curriculum and guiding students towards success. His vision continues to inspire us and for the growth and development of this institution. Now I request to please felicitate I request Sir to kindly say a few words.
Very good morning, dignitaries on the stage, off the stage, stalwarts of this field, oral pathology, students, students from various colleges, and my dear own students, and the faculty from our college. Very good morning to you all. It gives me immense pleasure to address this, gathering here, because it is a one-of-a-kind program which is being conducted by oral pathology year on year. And, submucous fibrosis, I heard it's going to be more on submucous fibrosis, and that's being a very common problem. It's going to be for any second person there's going to be a problem of submucous fibrosis. They don't even approach the doctors many times. Even in my private practice, I see the patients in the last thing. But when education platform like this has been created, the awareness has been created to many doctors here, and it's not only oral pathologists should be knowing about these things. The general dentist, everybody should be understanding about the oral submucous fibrosis, and they have to identify the problem at the earliest. So the students, I personally request you to take more from this conference, because I could see lots of stalwarts from this field of oral pathology are here, and they'll be giving their experience. Mostly I always tell that you can read the textbook, learn lots of subject, that is all wonderful. But the experience that you get from these stalwarts is invaluable. You cannot get those experiences, because the mistakes they have done, the things they have learned in their career is what they are going to share in the next 2 days. So please pay attention, learn from their experience. It's always clever to learn from others' mistakes. That's what my father used to tell me. So this is a time when you can learn from the stalwarts who have made mistakes, learned lots of things, and now they're going to give their knowledge to you, which is invaluable. So students, I personally request you to pay full attention to the conference. It should not be a regular conference. Pay full attention to the conference. It should be interactive. Any doubt, you can always ask the teachers here. They will all in all the things. So any conference should be something has to be an outcome of a conference. So I expect there should be a good outcome from this conference, and best wishes to the Department of Oral Pathology for conducting this program here, and I thank the Association of Oral Pathologists for giving us this opportunity to program in Saveetha Dental College. Thank you once again, and best wishes.
Thank you, sir. Now I request Dr. Nadeem sir, the Joint Registrar of MGR Educational and Research Institute and the President-elect of IOMP, as well as the Professor and Head of the Department of Oral Pathology in Thai Mugapage Dental College, to kindly address the gathering. I request you to felicitate.
A warm welcome to one and all. I'd like to thank all the dignitaries on the dais and off the dais, and the management of Saveetha for inviting me here today. It's indeed a pleasure to be here among all the stalwarts sitting here. My teacher, Dr. Ranganathan sir, senior stalwarts like Sivapada Sundaram sir, Dr. Ramesh sir, and I wish the program a grand success, and I thank Pratibha Ramni for having, from the academic front, to do so well every year to conduct this conference on a regular basis, and all the best for the conference. Please utilize the lectures and didactic lectures given by the stalwarts. I wish the students to take up this and go ahead. Thank you very much.
Thank you, sir. Now, moving on to felicitating our guest of honor, Dr. Vinay Hazare sir, who has come all the way to address us and to give us his insights on oral submucous fibrosis. We are truly honored to have Dr. Hazare sir, one of the senior most professors and a distinguished researcher and a visionary in the field of oral pathology, especially in OSMF. He has made significant contributions as the Dean of Government Dental College, Nagpur, and has earned recognition for both his work and research during his practice. His guidance has shaped the research in OSMF, and now we are privileged to have him amongst us today. We would welcome you, sir. Now I would like to introduce our Pro Vice Chancellor, Sir, Dr. Ashwani Kumar, Sir, the Pro Vice Chancellor of SciMax. Sir has consistently supported the academic initiatives and guided the university towards innovation and excellence. His passion for education continues to motivate all of us to persevere and to conduct more research activities in the entire university. So we welcome you, sir, and we are honored to have you amongst us, sir. Sir, I would like to kindly request you to address the gathering, sir.
Good morning to all of you. Dr. Vinay Hazare sir, who is the Lifetime awardee today. Dr. Nadeem sir, Shija madam, Dr. Our Dean sir, stalwarts who are in the audience, senior professors, we have delegate, our expert from Malaysia, who is going to take the workshop of the students. It is a great honor to be invited for this function amidst the galaxy of experts, and of course, very important, our upcoming dentists who will be learning a lot from this exercise. And this is a all-important conference on craniopathology and biology. I am a little odd man out. I am a vector-borne disease scientist who retired from ICMR as director of one of the institutes. But I was fortunate enough to be invited to join this great university. All of you know the history of this university. Our Chancellor Sir, Dr. N.M. Virayan, I am representing him, but it is very difficult to fit into his shoes. He has been a doyen from a very humble background, but rose to great, great heights, a builder of institutions, builder of careers, builder of experts, not only nationally but globally, with multiple institutions that he has created. And he calls this dental college as the Temple of Dentistry. As you enter this institution, on the left side, you see the temple, beautiful temple. And if you see the fascia of this college, it is being converted as if it is a temple. You can see the beautiful, statues of gods and goddesses that are coming up. Even on the gate of this dental college, if you look at Ganesha, he is holding scalpels and other instruments, dental instruments that you can see. That is the kind of passion and the importance our seniors attach, all the faculty members attach to the dentistry. But I have a strong connection with dentistry. The reason is my elder sister, my brother-in-law, both are dentists. Dr. Vimal Sikri, who retired from Punjab Dental College as dean. Their two sons are dentists. The two daughter-in-laws are also dentists. So I tell them, are you a boring family or interesting family? So they laugh. So I have a strong connection with dentistry in that sense. But I also feel that everything begins, your personality is judged not only from your persona or aura that you carry, but when you open your mouth, articulate, convey your knowledge. And tongue, as you know, is very, very important. It's part of our buccal cavity. We all know how, and of course you address several issues related to tongue as well. But tongue can win the world for you, and can repel the world. So, and I also understand that there is a strong microbiome in the not only in the gut but also in our oral cavity, which has several functions, very important functions, digestive enzymes, and along with mucus, that is also supplemented, and it goes finally into our alimentary canal. However, in our country, the problem is certain regions of our countries, there's a lot of habits of chewing tobacco and smoking, and you can actually see people are mindlessly doing that. And once they are induced in the younger age, they get into this habit, and then they cannot get rid of it. And finally, you can see that they can barely able to talk. When they talk also, you can see that how stiff is their, when they speak, or when they smoke also, this voice is hoarse, and you can make out. That's what Dr. Arvind was alluding to, that we need to educate the young minds. Maybe we can educate people at the school level and keep them away. And fortunately, in India, the data shows that the smoking has actually gone down. But I don't know about the chewing habits of tobacco and other things. You are the experts. You can not only advise the students or prepare students for in your profession for the future, but also as a part of social dentistry, if we can propagate this and spread this knowledge across the youth who are actually induced into this kind of habit, will go a long way in preventing the problems that you finally solve in the clinic. So preventive dentistry, I believe, is equally important, and I think that message should go out very strongly. So I congratulate Dr. Vinay Hazare sir. He is very respected oral pathologist, and who is being given a Lifetime Achievement Award, which speaks volumes about his persona and his work and his imprint that he's left in this specialized field. And also the teachers, senior teachers who are sitting here, who have molded several experts in their lifetime. They are equally capable, equally important. And from this university, on behalf of Chancellor Sir, on behalf of Pro-Chancellor Sir, on behalf of Vice Chancellor, I welcome all of you. And I hope these sessions will be very empowering, very educating, very enabling to not only our faculty but also our dentists. And also I welcome all the delegates who have come from various colleges from all over the country and also from abroad. Thank you very much for this opportunity, and I wish this conference a great success. Thank you very much.
Thank you very much, sir, for your kind words and description of our Temple of Dentistry. Thank you, sir. And it is now time for the most awaited moment, the Expert Award Ceremony. It's time to recognize and honor the outstanding contributions of some of our experts in our field. The award ceremony celebrates excellence in our field of oral pathology, oral histology, as well as in research. Now, I would like to invite our Pro-Chancellor, sir, and I would like to ask the others to join to confer the Lifetime Achievement Award to none other than our Vinay Hazare, sir. I request Dr. Monal sir to kindly introduce sir.
Good morning to all. It's really a great privilege for me to introduce Hazare sir. Hazare sir was my UG teacher, so it's a very nostalgic moment for me. So basically, sir did his BDS from GDC Nagpur and MDS from GDC Mumbai. And then he became a lecturer in GDC Nagpur. And he became a dean in the same institute he has done his UG. So, and he will be there as a dean for 20 years. So it's a really great achievement for anyone who did his BDS and become a dean and retired as a dean from the same institutes. As far as the sir's contribution to the field is, started very long back as a basic dental science researcher he has done in TIFR Mumbai, from where he started his as a research career, and as you know, and ma'am also described him, he's working in the specifically in oral precancer and cancers, and I think everybody here is following his footsteps and working for the OSMF, which is very major issue in India. Not only that, he has received lots of fellowships, he has lots of publications in the same fields. So I request ma'am to felicitate. Please give him a huge round of applause.
I kindly request everyone to rise. It's truly an honor to have sir amongst us, and we can give him this award. Sir's wife, Mrs. Hazare, is also here. So thank you, ma'am, for coming and gracing this occasion. Please, we would like to ask you to come on stage as well. Ma'am is an orthodontist. I now request sir to address the gathering.
Thank you, everybody. Thank you so much. I request Pratibha Madam to be seated, please. What a wonderful day in my life, and I am really honored to receive this award, Lifetime Achievement Award, from Dental College, faculty, management of Saveetha Dental College, who is NDRF number 1. And on my behalf and my institution, that is Government Dental College, Nagpur, I think we are 9th NDRF. I accept this award, and I am really thankful to our Dr. Ashwini Kumar sir. He has been definitely a guide, not only in vector-borne diseases, but this tobacco-borne cultivated diseases in India. Sir, thank you for honoring me with this award, and please convey my respectful regards to Chancellor Sir, Pro-Chancellor Sir, and Vice Chancellor Sir. And I'm definitely agree that your Dean is much smarter than all of us. All orthodontists, including my wife, is also, they are smarter. They make the person smarter. And really, it's honor that you have a very active registrar, and Varghese madam, So Dr. Arvind Kumar and colleague and teams and all my colleagues, senior colleagues over city, I am really honored when I see two Shivas sitting in front of me, SPS, all of you know, and the voluminous Shiva. I think I was his examiner at Ragas. And we have stalwarts, 3 R's. I keep watching movies, RRR. One of the best R is, Ranganathan sir. Another, Ramesh. These are the people whom we have spent, our academic careers. And now, coming up, stalwarts in budding stage is Ramya. I was impressed by her presentation at Belgaum conference, really honored me. She has a tremendous knowledge of oral histology or oral biology, what we call nowadays. And of course, my humble colleague, Madam Pratibha. So R also, okay. Anyway, I just wanted to make it very lighter, and staff and students, basically oral pathology is very interesting subject. And if you read oral pathology definition by Schaeffer, it's a confluence of clinical sciences and basic sciences and clinical dentistry. Now everybody is talking about confluence, Sangam. Everybody talks about Mahakumbh, where lots of people are taking holy deep, including our PM on 5th, and earlier to that, Mrs. Steve Jobs. She was christened or named as Kamala, something like by. So, but believe me, I am really impressed with the Steve Jobs lecture, which he delivered at Stanford University, and he described his career or lifestyle in 3 stages, quoting that you have to connect, you cannot connect looking forward. You have to connect looking backward and trust that this will connect to your future. And this is true with me also. I have been studying oral pathology definitely with passion, and I have been given a lot of opportunities to go Commonwealth Medical Fellowships and other things in 1994 with stalwarts like Professor Johnson and other things, and we made a history. So connecting dots, let me take you back to 2 eras, Vedic eras and the modern era. So let me take you back to the 800 CC BC, where Sushruta and Vagbhata, first century AD, they were they have described oral submucous fibrosis. But there were a lot of things which were not properly understood. Everybody quotes Vidari is synonym to submucous fibrosis. It is not. 800 BC, Vidari was described by Sushruta to call as a noma or cankering ovaries, or more so. The symptoms are that, the sloughs comes out. And we have never seen a slough in oral submucous fibrosis. Those were small vesicles. So first thing, when we did study with Professor Johnson, historical aspects, that we proved that Vidari is a misnomer. Secondly, Vagbhata, I have showed you, he described all the Ayurvedic symptoms which are now relevant to oral submucous fibrosis, which I will definitely elaborate in my discussion or panel discussion. So Vagbhata said it is a Vataja Saresara. So real description of oral submucous fibrosis is not Vidari, but Vataja Saresara described by Vagbhata in 1st century. So that was Vedic era. Then of course came the 20th century, and stalwarts like Professor Pindberg, Dr. Daftari, Professor Vishwanathan, and all of them, they have contributed to the understanding of oral submucous fibrosis. So this 20th century, because Tata Institute of Fundamental Research worked from 1966 till 1999. So till 2000, the entire work was done by these guides, mentors, teachers, like I said, Dr. Daftari, Professor Johnson, Samanvarna Kulasurya. But we were getting trained under them. And then the 21st century, the real progress in the field of submucous fibrosis has taken place. All over India and globe, there were a lot of publications, and maximum publications came from Indians. Maximum contribution came from Indians. And I'm very proud to quote Professor Ranganathan has edited this book, Oral Submucous Fibrosis, a textbook on oral submucous fibrosis Springer in 1923, co-edited by Samanvarna Kulasurya. It had 21 authors, but believe me, 15 of us were Indians. Myself, Professor Ranganathan, Kavita, Professor Paul, Professor Rajiv Desai, our from Calcutta, Professor Jay Gopal Ray, these are the people. And Kondaya sir, Putru Kondaya sir from IISc Bangalore, they all have contributed. I may have forgotten all those 15, 16 names, but believe me, this is the Bible for oral submucous fibrosis. If anybody wants to understand oral submucous fibrosis, the future directions are where. Lifestyle management, all these we are going to learn in this symposium. They all are there. And of course, I must mention the textbook edited by SPS. It has, these are the real books. Please read. What definition I have quoted you, it is from the preface to the 4th edition of Schaeffer's, now SPS. So please read few books, few pages. Preface you must read, you will understand. And you go back to the last pages, and of course in between you have to read. So this has been my philosophy or my way of working. I am really honored that these things were there. But basically we have a very great tradition for teachers, and all this, our credit, our success belongs to our teachers. We have, I think now, 6th generation of postgraduates since Dr. Dholakia started postgraduate studies in this field. So 6th or 7th maybe, Arvind will correct me, So, and there are our alumni working overseas. Dr. Anand is here. You can see how he is, guiding or conducting protocol-based studies. And one of my students, Maithili Srinivasan from Chennai, she is heading the oral oncology lab, oral biology lab at Indianapolis. So these are and many, many more. So youngsters, please consider oral pathology as a clinical colleagues. Take interest. There is a lot of things to learn and serve the humanity. I dedicate this award to all my gurus, Dr. M. V. Lele sir, especially late Professor Johnson, and Bhishma Pitama of this region of the oral pathology, Dr. Dolakia, and late Dr. Vishwanathan sir. And I am really honored to receive this award. Thank you so much. Thank you so much.
Thank you very much, sir. So moving on to the next award, it is given for the distinguished service in oral pathology, and the award goes to Dr. Ramesh, sir. Sir is the former Dean of Mahatma Gandhi Dental College and is the teacher of all the teachers. I request everyone to join in giving the award. The next award is to none other than Dr. Ranganathan sir for his distinguished service in oral pathology. Again, one of the senior most professors has been holding official memberships and positions in various institutions. In the International Association of Oral Pathology, in IAOMP, and name it, and sir has been instrumental in so many different innovations in our field. So the next person we would like to honor is none other than our very own Dr. SPS sir, Dr. Shivapada Sundaram sir, the author of Schaefer, as all of us know, and a pioneer in the field of forensic odontology as well. So we would like to give the award of distinguished service in oral pathology for sir as well. So now our Schaefer textbook has a face, you can see sir. Sir's the one who has written it, edited it. So the next award is to Dr. Nadeem Jeddi sir, Professor and Head of Oral Pathology of Thai Mukambikai. For leadership in oral pathology, sir has held many positions in our association. So the next award goes to Dr. Manju E for excellence in scientific research. I request Dr. Manju E from Tirunal Institute to kindly come up on stage to receive the award. Next, I would like to call upon Dr. Manoj Komath to receive the award of Trailblazer in Research Dissemination, also from Tirunal Institute. Sir is instrumental in various projects in the Make in India. I request the student back. Next award goes to Dr. Deepa Gurunathan. She receives the Research Impact and Engagement Award. Ma'am is the Professor and Head of Pediatric Dentistry and also the Associate Dean of Research. Ma'am is a partner in various research innovations in our college. The next award is to Dr. T.N. Uma Maheshwari Ma'am. Ma'am is the Professor and Head of Oral Medicine Department and she's an ardent researcher. Her field of interest is oral biology, oral medicine and as well as forensic odontology. Next is Dr. Arvind Babu Sir. He receives the award for exceptional writing in oral pathology. Sir has released umpteen number of books in oral pathology which correlates with the clinical practice as well. Thank you, sir. Sir is the Professor and Head of Balaji Dental College. Next award goes to Dr. Devi and she receives the Best Oral Histology Teacher Award. Congratulations. Ma'am is from Adi Parashakti Dental College. Next, I would like to call upon Dr. Indra Priyadarshini and ma'am receives Best Researcher Award for her research contributions in the field of oral pathology. The next award goes to our very own Dr. Sharada ma'am. Ma'am also received the Best Researcher Award. Ma'am has received various grants and is an ardent researcher from Ramchandra Dental College. Ma'am is a professor. Thank you everyone for honoring the researchers and the scientists with the awards. Now I request... Okay, another award for distinguished service in oral pathology was also bestowed upon Dr. Tamil Selvan sir, but sir was not able to come because of some immediate urgent commitment. But thank you sir for your service as well in the field of oral pathology. We would send across the award to you, sir. Now I would like to invite Ramya Ramdas ma'am, the professor and head of oral biology and also the associate dean of extension activities, to deliver the vote of thanks. Ma'am has been instrumental in this conference, and without ma'am this wouldn't have been possible. So we are really happy to have ma'am to deliver the vote of thanks.
Gratitude is the most important virtue of mankind. I am humble to stand amidst this august gathering. I sincere, heartfelt thanks to the architects of this visionary education institutions, whose tireless work is evident in every brick and space of this institution. I thank all the dignitaries who are on the dais and off the dais who made a point come to this gathering. We are humbled and honored to have all of you here. The aura which your presence have created here is something tremendous, and we are truly blessed. I sincerely thank all the participants who are here, both online and offline. Every time we roll out a flyer, the response which we get from certain specific institutions and groups is really mind-boggling, and we are very, very happy, and we feel very honored to your continuous support. Of special mention, Sri Ramachandra Dental College, Adi Parashakti Dental College, RV Dental College, Bangalore, Balaji Dental College, Chennai, Mada Dental College, and many, many more institutions all around India. We are very proud to say that we have around 400 plus registrations today, and many of them are watching it online. In spite of very big events happening today, we are very, very honored, and we really bow down to all those who thought that this platform would be a very good platform to learn and at least receive some kind of knowledge sharing. And many, many thanks to all the eminent scientists from Sri Chitra Tirunal, Dr. Manju and Dr. Manoj sir, who is here with us, not only in their presence. We are honored that they have come here all over from Trivandrum. The most important thing of this conference, which I feel it's like a silver lining in the cloud, they had agreed to publish our full text papers of our conference, full text in their prestigious journal, Trends in Biomaterials and Artificial Organs. And my heartfelt thanks to the team, Oral Pathology and Oral Biology, without whom this program would not have been possible. And every hard work which went behind has made this third edition possible, and we are very thankful about it. I also sincerely thank Pratibha ma'am for giving me this opportunity the third time. Thank you so much.
Sorry, before the national anthem, I would just like to give one more award which got missed in between because the busy commitment of our surgeon. So this is Dr. Vinod Krishna, who receives the award of the Rising Star in Oral Oncology. We're extremely proud and happy to give this award to him. He's our very own alumni, and he's done the Fellowship of Oral Oncology from Malabar Institute. He has been a surgeon from day one of his career of BDS itself. So he used to call himself a surgeon from the year he joined BDS itself. So that's the kind of interest he had in the subject, and now he's really an oral surgeon. So I think that's how we should manifest ourselves and become one. Thank you. Now I request everybody to rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
I request the guests to kindly be on stage for a picture with the organizing team.
testing. Hello, hello. Check. Hello, test. Check. Hello, test. Test. Check. check, check. Hello, check. Hello, hello, 1, 2, hello, check. Check, check. Hello, 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 check, check, check. Hello, test, check, test. Hello, hello, test, check, test, check, test. Hello, test, check. ಕರೆಕ್ಟಾ ಸೌಂಡ್ ಇಲ್ಲ. Hello, test, test, check. test, check, hello, test, hello, test, check, test, test mic 1 2 3, hello, testing. ஹலோ டெஸ் கட் ஆகுதா அவ்வளோதான் இது மேலே எதுவும் பண்ண
Good morning, everyone. Let us all start with the scientific sessions of the day. We'll start with the plenary session 1, Symposium on Oral Submucous Fibrosis. I would like to call Dr. Pratibha ma'am to moderate this session.
Good morning to one and all. As always, it's my proud privilege to, I'm just a moderator of this session because, as mentioned before, we have the stalwarts in the field of oral pathology and who have done real, genuine work in the field of oral submucous fibrosis who would be taking over the session. And it's my proud privilege to welcome Dr. Muthushekar sir, our professor, oral and maxillofacial surgery. And very important point is many of you, he's there right from the day one of Saveetha Dental College, and we are really honored to have you here, sir. And the strong base of the oral pathology in our college is because of the strong base of the oral surgeons who work tirelessly here in coordination with our department and oral medicine, because of which we are able to come out with so many papers. Thank you so much, sir. It's our proud privilege to welcome you, sir. I deem it a great honor to welcome Dr. Dinesh Daftare sir. He is online and he is chairing this session. Students, it's like as Dr. Hazare sir had mentioned in his speech, he has done the pioneer work in this field of oral submucous fibrosis, and he's almost like a guardian of this entire subject. And in fact, in our association, we have a separate symposium named after him in our IOMP conference, and it's our great privilege and pleasure to welcome Dr. Dinesh Daftare sir, who has joined us online. Briefly about Dr. Daftare sir, he's passed from Bombay University, and then he has studied extensively under J.J. Pinberg sir, who is the leading authority in oral cancer and pre-cancer at Copenhagen, Denmark. He has been the professor of oral pathology at Nair Dental College and also honorary pathologist, basic dental research unit at Tata Institute of Fundamental Research. And in there, he started to do lot of active, very important epidemiological work. Though being an oral pathologist, he has done active epidemiologic, histological and intervention studies on pre-oral, we used to call it as pre-cancer. So oral pre-cancer and cancer in very important thing is he has done this work in rural parts of India. That is something which needs to be taken care of, because we know that's the place where it's generally neglected, because in cities people come in and go, but he has done his pioneering work in rural parts of Maharashtra. His study has been supported by NIH US since 1966. So and he's also been a part of the WHO Collaborating Center for Prevention of Oral Cancer. Sir has his CV is so big that it's a true honor to have him in this consensus meeting, because it's a great privilege for all of us here. The other chairperson who is is a person who has already been introduced to us, Dr. Vinay Hazare sir, and as I told, he has also done lot of work along with Daftare sir, Johnson sir, and so many other pioneers in the field of oral submucous fibrosis, and we welcome you, sir, onto the stage. It's also a proud privilege to welcome Dr. K. Ranganathan sir. He has, in southern part of India, he has done lot of work and is still doing a lot of work in oral submucous fibrosis, and so he would be also sharing his thoughts, as this is going to be a sort of consensus meeting. The whole idea had actually started when we had with our Pro-Chancellor Dr. Deepak had wanted a consensus meeting, especially in this oral submucous fibrosis part, as this is our disease. So he was always wanting to talk about this, and then when we had a meeting in Malaysia, and I'm sure Dr. Anand was there, and Azare sir, we had discussed that why are Westerners talking about our disease? It should be something like the consensus should be from the people who are actually working on the disease. And so we have people who are actually working in the South Asian part. We have Prof. Tilakratne, who is going to join us from Malaysia, who has also done a lot of work in this particular field. And we thought that there should be a consensus where we are able to bring out something and give it to the Western world rather than them giving us the idea. So that is the old idea of this entire consensus. I'm really grateful to all the panelists who have come here because all of them have done very much individual work in this particular field. So at first, welcome Dr. Hazare sir and Dr. Ranganathan sir onto the stage. And also those who are present, so I'm just going to introduce who are offline here. So we have Dr. Punya, who is Angadi. She is also a very sort of, they say a replica of me because both of us are very fast, very running around here and there. But I would like to mention to you that she has been doing original work in this and has lot of publications. Many of the students here remember Angadi et al. It's none other than Punya, who is very much here, and we are really honored to have Dr. Punya here. And we request you to come onto the stage. And Dr. Punya is currently working as professor at KLE Institute of Dental Sciences, and also she is the assistant director of research in the KLE University. And so that tells you how much of work she does, because she keeps traveling from Delhi, getting grants and this and that. So I know she's a pretty busy person. We are really honored to have you here, Punya. It's also, so we have a person from the west, we have a person from the south, we have a person again from sort of west-south, that Punya, and now we have another person who is representing the eastern part of the country, Professor Dr. Jayanta Chattopadhyay, and he has come all the way from Kolkata, and we know that lot of work also comes from their side, part of the world comes from their institutes, especially Dr. Jayagopal Ray. I think he has been doing lot of work, and he is also one of the main stakeholders for the oral submucous fibrosis, and in his own footsteps we have Dr. Jayanta, who is here representing the eastern part of our country, and sir has done his UG and PG from University of Calcutta, and now currently heading the Institute of the Kusum Devi Sundarlal Dugar Jain Dental College. Sir has also a clinician, that's very important. Like we have clinicians here, we have all, 4 of them are having clinics, so they're all clinico-pathologists, and I think it's very, very important because oral submucous fibrosis, we get to take biopsies only when they suspect an ulcer. So as a role of a clinician here is very, very important, and that's a mainstay part which you would like to tell here. Along with our distinguished guests here, as I had mentioned, we have 3 panelists who are joining us online. Professor Dr. Tilakratne, he is, as all of us know, is one of the person who has done lot of work in this oral submucous fibrosis. He still continues to work on the same. I remember Professor Ranganathan bringing him way back in 2010 for the first conference in international conference which was held here, and I think that was the first time I think we got to introduce him, and then subsequently we have been working in close coordination with Prof Sir, and he's a pioneer in this field, and Dr. Anand also works with him, so it's a proud privilege to welcome Prof Tilakratne, who has joined us online. And next person is Dr. Raghu Radhakrishnan. He's a professor from Manipal Dental College and Hospitals, and as I had mentioned, he has also been doing and publishing lot of work in this particular field. Currently he is working in University of Oman in a different role as an academician, but still continues to pursue his passion for research. He has been on and off going to UK doing a lot of work in this particular field, and I think he'll give us a great insight on the topic which he likes the most, which we have a lot of questions for him. Last but not the least, we have included a very young, enterprising personality, Dr. Karishma Desai. She is currently doing a research fellow in Japan. And why we wanted her to be in this is she's been doing a lot of work with Hazare sir and done a lot of publications on the same. in certain very important aspects of submucous fibrosis. But as students, she would be helping or she would be guiding you all on what are the, we may think is OSMF done and dusted. There's so much of work done, but still we feel there's no solution which has been sought of. So she would be able to guide you on what are the various prospects, future prospects of this particular subject, which is, I think, of most importance. As still now, as my ma'am told me 25 years ago, Dr. Tia Sati ma'am told me, Pratibha,
Recording
once
in
you finish
progress.
Yeah, but they should at least
by the
communicate
time
with
you
us and
retire, at
tell us
least
that
try to do
what you are
something
doing
for
here.
oral submucous fibrosis. Still, I am only doing basic research, staining or doing molecular studies, but nothing has become translational. So we just hope through this consensus meeting here with the stalwarts, we are able to drive in some consensus that we can put forward for the next generation people to take on, and something more can be done to it. I am also privileged to have Dr. SPS Shivapatasudan sir here, because sir is also in this part, has a lot of publication with regard to this. Thank you so much, sir. So I hand over the session to Dr. Hazare sir.
Good afternoon, Vinay.
Good afternoon, everybody, and welcome to this symposium, Fostering a Standardized Protocol for OSMF, Clinical and Pathological Consciences. As you know, a lot of interest has been generated on oral submucous fibrosis since 1952, and incidentally I was born on that year, so that's why Lifetime Achievement Award was given to me, probably thanks to the topic, very interesting, and on oral submucous fibrosis. In my introductory inaugural speech, I already briefed you about historical aspects, but I would like to make some important points for the discussions to carry forward. Ours is a protocol meeting and consensus meeting, so it needs to be really standardized. So basically, amongst historical perspective, we all have been talking that Schwartz in 1952 has described oral submucous fibrosis in 5 East African Kenyan ladies. It's true, but we couldn't find Schwartz's abstract paper which he described. He presented in International Symposium at London in 1952. Throughout the global search, myself and led Professor Johnson couldn't find Schwartz's abstract, and it was not produced anywhere else in any of the libraries. So when we scanned the literature, we saw that basic work was done by Dr. S.G. Joshi in 1949 from ENT surgeon from KM Hospital, and our own Dr. Damanlal, the oral surgeon, Damanlal Sarin in 1953 produced a wonderful paper. He called it a diffuse oral submucous fibrosis. And then the Schwartz. So whatever we say, Schwartz in 1952 has described OSMF, no. It should be Joshi, Schwartz and Damanlal, contemporaries in 1952-53 described oral submucous fibrosis in details, and now we have seen how many, after 70 years, we are still, the basic given by Damanlal and Joshi is still very valid. Second aspect I wanted to clarify, Vidari is misnomer. What Sushruta called Vidari was a tonsillar cancer or peritonsillar cancer or cancrum oris. It is not, because there is no sloughing in oral submucous fibrosis. We have seen thousands of oral submucous fibrosis, and not a single case has a sloughing. So it is basically a noma. But again, I told that Vagbhata in the 1st century described it as a Vataja Saresara. So it has all, of course, Ayurvedic and Sanskrit scripture showing the inability to open the mouth, the fibrosis, intolerance to hot and spicy food, and basically habit to the areca nut. So I should clarify here, it should be quoted not Vidari, but a Vataja Saresara by Vagbhata in 1st century. That was the Vedic area. And I told you, 20th century belongs to Tata Institute of Fundamental Research and Pindbar. Because almost for 1966 to 2000, they have worked, they have hundreds of publications and sound understanding of oral submucous fibrosis with international collaborators like Professor Johnson's. TIFR has produced the wonderful work, and in fact, if you remember the study by Murthy et al. From TIFR, 7.6% malignant transformation is still the gold standard for the oral submucous fibrosis. There is an enormous literature, and we should not forget the contribution of TIFR in understanding the oral submucous fibrosis. Basically, Professor Johnson, Dr. Daftari, Professor Gupta, all these people have worked so hard. So that was, 20th century. Now the 21st century belongs to us. Those who are born after the disease was conceived. It means 1952. Me, Professor Ranga, Professor Raghu, all youngsters, including the smart Ramya and what's your name, Punya. See, this is the, era we have worked. Of course, under the guidance of late Professor Vishwanathan, Dr. Daftari and Professor Johnson, there, just to name a few. And people from Malaysia have worked under the guidance of Professor Roshna, like Anand, and there are two Anands, like another very familiar Anand and Anand Ramanathan, okay. So there are global studies, and presently the global studies are being led by Professor Saman Varnakumar Surya. His contribution in understanding oral submucous fibrosis is tremendous. So also of Professor Tilakratne. We are going to listen to all of them. And this century really, this 21st century, really we are going to listen to Professor Raghu. He has a sound understanding. And of course it will be lifestyle disorders by Dr. Anand. Jay Gopal Ray and all these colleagues are speaking. So it's a wonderful compendium, very good platform, and Punya will be adding molecular biology and other things. And Karishma means, something charismatic. She really puts all our, into very wonderful text. Me, Professor Saman Varnakumar Surya, and Karishma has come out with a new concept that is known as the dual pathologies. Oral submucous fibrosis have now a tendency for the dual pathology. That is submucous fibrosis and PVL occurring, proliferative verrucous leukoplasias are occurring at a regular interval. Out of 6 cases, we had 4 submucous fibrosis, and it is a disastrous disease. All 6 patients died within a follow-up of almost 5 to 13 years. That paper have been produced by us, and that is the dual pathology. So we must understand. And now treatment protocol, we have to act again according to the disease pattern. Because oral pathologist tries to understand the oral diseases so that it can be adequately diagnosed and adequately treated. So treatment is also our part. So for dual pathologies, we have given oral metronomics chemotherapy, which is a talk of town in recent chemotherapy. It's oral form. Oral metronomic chemotherapy has done wonderful things in the studies by Tata Memorial Hospital. It has been strongly advocated. So for dual pathologies, we suggest oral metronomics chemotherapy, which is a combination of antimetabolites and COX-2 inhibitors. So this is in the treatment protocol. I would like to add that treatment protocol should comprises of all other patterns, including lifestyle modification and oral metronomics chemotherapy and Erica nut cessation. We always talk about the tobacco cessation. Nowadays, even e-cigarettes are being, prohibited. But we are not strong for the Erica nut prevention, Erica nut cessation habits. So, lastly, at a strategy, we should come out with Erica nut cessation programs, and consensus should include clinico-pathological, as I have told you, treatment aspects and the preventive strategies. Thank you so much. We have wonderful panelists from the globe, and definitely Professor Ranga will be summing up after the presentation. And I welcome you, Dr. Daftari sir. Thank you so much.
Thank you so much, sir, for that introduction. And so going straight on to the consensus symposium, I think the first, Professor Dr. Jayanta, sir, we've had certain queries, and so accordingly, there are few questions which we have put up, and sir would be giving his output with regard to that. So the question, the base part of it, or the broad concept which he would be touching on, would be why are the regional variations in oral submucous fibrosis prevalence, and whether there is a link of how much of Erica consumption is there. So accordingly, the questions with this aspect which was put up was, what are the different regional variation of incidence of oral submucous fibrosis in various parts of India, and why people, what are the reasons or what are the various factors because of which Erica chewing is very prevalent, especially in India? What are the reasons? So that would be the first part of his answers, which he would try to clear up. And the second part would be, he would also be touching upon, because as sir had said, we have to touch on the treatment. So on touching the treatment, it has to be always on the Erica nut part of it. So he would be briefing on what are the various forms of the Erica nut, what are the recent forms, and why is that some people, why some forms may be more making the person susceptible, how addition of the age-old snake lime and tobacco in that could alter and make the patient susceptible to OSMF, and what are the various and how proprietary formulations generally than the raw, whether the proprietary formulations are more harmful than the natural products. So this would be the very, very, very important aspect which he would be covering. Thank you so much, sir.
Can I go there? Good morning, everyone. My PG guide, Dr. Arapal, always scared me. He will call Dr. Rajare as my external. So today, his wish has come true, and he has come with his full team. So, anybody owns a Erica nut tree plantation in this house? None of you? Okay. The part from where I come, the geopolitical section, West Bengal, Bangladesh, we were the same, southern Assam, in valley part of Assam, Bihar, then Jharkhand, northern Orissa, until this wave of rapid urbanization, all of us, we used to have some Erica trees in our house. So, oral submucous fibrosis is essentially closely linked to Erica chewing of Erica nut. And how prevalent, why so much of Erica nut chewing? See, we use Erica nut, somebody is born, we give the priest Erica nut. Somebody comes home, we dignifies him with Erica nut. And we even worship our God with Erica nut. And even if suppose we appoint a contract killer for killing my enemy, I solemnize that contract with the supari. Supari killers, all of us we have heard. So this prevalent is Erica nut. Now, if we go, suppose the NCR area, Punjab, Haryana, UP, Delhi, Erica nut chewing was not that prevalent until say 80s, mid of 80s, Erica nut chewing was not that prevalent. And if you see the prevalence rate, this keeps on changing. So this prevalence incidence rates, you have to have a modern, means recent study. The recent study shows somewhere around 3.6 to 6.8%. As we come down a little to the western part of, and most of the things that is chewed is gutkha and pan masala or flavored supari. As we come down a little to Gujarat and Maharashtra, and the prevalence goes up. What is that? It will come somewhere around 8 to 14%. And most of this chewing is in the form of either freshly prepared mawa, where they mix lime and tobacco, or gutkha again. Come down south. Most of the erica is produced in Karnataka and Kerala. India is the highest producer of erica, and 40% of all erica is produced in Karnataka. So you have the highest, in southern part of India, the highest prevalence of oral submucous fibrosis is in, not surprisingly, in Karnataka and Andhra Pradesh. Kerala does a little better, that has other socioeconomic conditions. And the part from where I come, Eastern India, it has an intermediate range from somewhere from 6 to 10%. But the worst part is probably northeast, 10 to 15% prevalence of oral submucous fibrosis. So without forget about these numbers, there are certain things which we as practicing oral pathologists, or if we have any undergraduate students over here, as practicing dental surgeon, we need to convey to the government. What are the things? Number one, acceptability. Any society should not accept a bad practice, however prevalent it can be. So, wherever we see use of erica nut, we should give a message that no, don't use it for our religious practices. This is ultimately harmful. This is taking lives. Next, availability. Erica is easily available everywhere. Even in trains, these days if you travel by local trains, you will see they are selling chocolates. Chocolates. The vendors, they keep on selling. They are not selling chocolates. They are selling this erica nut product. Third is affluence. As India is becoming shining India, we are increasing our economic standards. Remember, erica products are predominantly used by poor people. So oral submucous fibrosis you will see in poorer parts of the country. Orissa, these rural parts, they have a higher prevalence of erica consumption and submucous fibrosis. And lastly, awareness, as Seth said. You go to a movie, what is the first thing you see? You see a large malignancy, and then they say, don't use tobacco. Right? Have you ever seen a small poster anywhere, don't use erica? So all these things we need to convey to the administration. What is the second question? Yeah. Who said that? Various forms. So these I know very well. I don't need to consult any book. I have seen in my house. What is it? The supari or the erica nut you can use as a green product. What is the green product? It is not yet ripened. Then you place it in water and in the morning you start chewing it. This has got a very high concentration of alkaloids. All the adverse effects, what we have, we'll talk why in subsequent form at the time. So this has got a very high amount of erica alkaloids. The second one is the sun-dried form. Now you see a nut that has been sun-dried. So it becomes exuberantly hard and you are placing it against a mucosa. So in addition to a chemical injury, you are actually adding a physical injury to it. The third form is the boiled part, and this is, a poison doesn't have a safety index, but this is the safest form where most of the alkaloids, they leach out while boiling, right? Now, fourth part, when we mix it with lime. Now, this has got a story. Erica is very difficult to preserve. Now where it is produced? Eastern part or southern part of the country. Where it will go? To the western part or northern part. By this time, it gets infested with fungus. So what they do? They mix it with lime. And now what the lime does, all the effects, good effects, if you see a little, do we have undergraduate students over here? Yeah, PGs. So why people chew Erica? Huh? Have you anybody tasted Erica nuts? None of you? So you can't fight a poison like that. Erica nuts are very bad to taste. Very bad to taste. They are bitter, pungent. Then why do I chew it? Then anything bad, suppose, I don't know whether I should say, sir, I'd any day prefer a katora of rabri than a bottle of whiskey. So chewing Erica is a conditioned reflex. Always. Why? What happens? It has basically got 4 alkaloids. Ericolin, I am going very quickly, ericadin, guvasin, guvacolin. All the ericolin, they gets converted to ericadin. And then what it does, 4 systems are there in our body. Cholinergic, it has got again muscarinic and nicotinic. This muscarinic has got 2 receptors, and what it does, when I start chewing, it increases my cognitive ability and increases my memory. See, it is fantastic for the students, we'll see in some point of time. And then GABA and DOPA, what it does? It increases the secretion and reduces the reuptake. Now what happens? I have a euphoria and at the same time anxiolysis. So I have no more down. And with that, remember, we have a memory and cognitive learning increase. And lastly, serotonergic. Now what happens? With the modulation of the serotonin receptors, it is a mood elevator. So I'm having a euphoria, I'm having a mood elevation, and I am having a fantastic time, anxiolysis. So it's a perfect take before your oral pathology vibe. But with that, what it contains? With that, it contains polyphenols like tannins and flavonoids. Reactive oxygen species is produced by oxygenation of ericolin, and with the oxygenation of these polyphenols, they have high metals, copper, zinc, iron, and with that, we have some small amount of carbohydrate, proteins and oils. Now when I'm chewing it, only Erica nut chewing, take home messages, 3 things. Only Erica nut chewing will give me a euphoria, fantastic, but not that much. When I mix it with lime, now what happens? Lime quickly hydrolyzes all the alkaloids. This is number 1. Number 2, what it does? Anybody has seen how a pan is given? Yeah? Nobody has seen? Sir? So I'll ask, if you are here. Can I ask, sir? So once you are handed over a pan, what is the next thing that vendor hands over to you? Anybody? They give the betel leaf. I'll answer it, sir. Sorry. So they cut the stem of the betel leaf, give amount of lime and give it to you. Right? So you place the pan, and remember cigarettes, pan, they place it on a habitual place. Means one who is having pan from the right side of the buccal vestibule will keep on having pan from the right side of the buccal vestibule. And after he places the pan, he will take that lime and place it on the mucosa. Anybody knows about the pH of the lime, select lime? It's somewhere between 10 and 11. And when you place it on the mucosa, what happens? It creates an inflammation. Chronic inflammation, excess vascularity. Now, erica nut or ericaline is 85% soluble from the oral cavity. And with that, now I have got high inflammation, means high vascularity. And the lime is breaking down the ericaline very quickly. And what is the normal peak onset? Within 3 minutes you place a erica nut, you are feeling good already. My viva was bad, but I am feeling good. And when you mix it with lime, you get a sudden shock within 90 seconds. So now lots of alkaloids are getting into your blood and you are having a quick kick, if I may say so. This is the basic point. See, you can't fight a poison without knowing what advantage it causes. Right? So this is the main, but what is the disadvantage? The disadvantage is it increases the creation of reactive oxygen species and the oxygenation of the polyphenols. So this is why people who are using lime and erica nut together are in more danger. And you add tobacco to it, that has a synergistic effect. But the third part comes a deadly combination. What is that? The proprietary formulations. What are proprietary formulations? Before 80s, 85, 86, Sir must be knowing it better, we had a fantastic advertisement. What was that advertisement? A person is distributing a particular brand of this erica nut to everybody. And then a tall person comes on Medelia, so he shows a whole chain of it. Anybody remembers? This line must be right. So what happens? Now see who Sir makes a homemade pan. So ma'am needs to occasionally. Fantastic, sir. Fantastic. Sir, you remember Dr. Subrata Sarkar, sir? Yeah? He used to bring a tiffin carrier for his lunch. And another tiffin carrier, he was the head of the pedodontia and later became the principal of Dr. Aramed Dental College. And another tiffin box, I'm telling the truth, sir, carrying the pan. So ma'am had to wake up at 8:30, start preparing those pans at 8:30, cut them, apply lime, give tobacco, give the supari. Now things are made easy, don't worry. Cut the sachet and put it in your mouth. And what they have done, they have ground the erica nut into fine powder, excess surface reaction. So quickly I will have a very good kick. Right? So this is the main problem. And with that, what they have added? See, I told you for the first time, suppose Jogesh is there. So Jui offers him a sachet of tobacco or a sachet of erica nut. It tastes bad, right? So nobody will take it. So they have added sweetness, good mouth freshness. So now what will happen? Yogesh will eat it for the first few days for the taste that lives in the mouth and will gradually get used to the high level of alkaloids. So this is and this day, if you go to any good malls, you have health drink from erica nut juices. Fantastic health drink from erica nut juices. Lastly, I have 2 points to make. Number one, if you see from 91, those who has grown up in 90s, in 91, 92, India changed a lot. Good roads were built. Previously, my father used to have a bike, sir. And it took him 5 years to get that bike from the bank. Now you can go and walk into the best BMW shop and get a car just now, right? So India changed. Good roads were built. And with that, what traveled? What traveled was the sachet of shampoos, you see, these days, small sachet, they were never there in our childhood. Small sachet of coffee, even if you go to the most rural sector, you will get those things. And you will get small sachets of suparis and gutkhas with them. So, even before education, health or awareness could travel to the remote part of our country, the poison traveled. And these people, and with that some easy money. So what happened? They started taking supari, erica nut very quickly. And sir can say it better. We have a huge surge of oral submucous fibrosis somewhere from 95 to 96. But that's not all. If you think of the social, anybody is there from UP? No. So I'll tell you one story and finish. Most of these proprietary formulations, they have their factories in places of Kanpur, right? All the big factories. So these registered factories are in Kanpur center and they have a strong quality control. But there are factories who produce somewhat generic version of these suparis that were places that are made in places like Dadanagar. There is a place of Kanpur, Dadanagar. Nobody ever inspects those factories. And if you go in the morning, you can't enter the factory. What happens? Huge truckloads of cements are getting into those factories. So what are they doing? In a pan parak, I shouldn't name any. In a pan masala factory, what the cements are doing? What these cements are doing? The normal cement, Portland cements. They are repressing the lime, cheaper version of lime. And if you actually try this sometimes, place a pack of gutka under water and leave it overnight. You will see in the morning, it has solidified. Because cement is there. And with that, what is happening? You are placing heavy metals like cadmium, arsenic, silica, coarse abrasives like alumina. Now 30 years we have been taking, and now these big factories, the factories which are under regulation, buy these cheaper suparis from the unregulated factories, place them under their packaging and sell them to us very conveniently. The profit goes up. So this is the greatest thing. And all our experiments, they will know it better. When we place it, we place erica nut extract to a mucosa or a cell culture. Nobody places a cadmium or a lead or an arsenic or an aluminium silica to see. And even there are some reports which we never got, said there was presence of radioactive materials, very minor, but because cements come very easily. Nobody controls their quality. So this is the greatest curse we have. This is why proprietary. And what is the proof? I am saying that is not the proof. If you are only chewing erica nut, and if you are chewing the proprietary formulations, the average age of having oral submucous fibrosis is 10 years younger. What is the malignant transformation rate? If you are having any brands, it's 9%. If you are only chewing erica, it's 2%. Thank you everybody. Thank you, sir.
Thank you so much, sir. Actually, as you had mentioned, some people, your thoughts on it, are starting to use this areca nut for certain treatment. Is it true, sir? I have seen Alzheimer's they are using, and what would any of the panelists here would like to take a thought on it? Because already this is, it's like, what can I say, using a poison for a disease which may have we have people in the older age group, and are we introducing something else, or what effect it could have? So any of the panelists could help us, or anybody take us on this part.
That's a very good question actually, and that goes back to its addictive properties and effect on the central nervous system. It increases the cognition. That was a big point you made. And you know, Alzheimer's, there's a decrease in cognition, point number one. It's got other properties too. It's got anti-helminthic properties. It's a mild stimulant. I know for a fact that when I first tasted areca nut, I had bradycardia. It reduces the heart rate, it makes you feel good. I developed severe bradycardia if I take areca nut actually. Some people are sensitive. So it has a lot of physiological responses. The problem is, those physiological responses are a fraction of the side effects of areca nut. And when you start using them in large quantities, it becomes a problem. I'll give you a very good analogy. Everybody is aware of Siddha medicine. Anybody who doesn't know what Siddha is? One of the fundamentals way in which Siddha works is using heavy metals. When used in traces, they've got a tremendous advantage. But when you use it in high concentration, they shut down the kidneys actually. And this is interesting because Professor Saman actually spoke to me about a month back. He was looking for something for arthritis which was marketed in Amazon. And then he looked at the contents and he said it contains arsenic and heavy metals. Ranga, how are they selling this in Amazon? The point is, it would have been mentioned that you take a very small dose, maybe once a month or something. But once you start seeing the effects, it becomes a problem. Quickly, just an aside, I don't know how many of you read the news about a family, in one single family, about 3 generations developed chronic renal failure within 2 weeks. Did anybody read that news? It was a year back in the news actually. It's because mercury is used in whitening creams and to make you fair. So in traces they have a good effect, but when you start using it in large quantities, the side effects overwhelm the actual effects which you're supposed to use. So it's a double-edged sword. And there are publications. In fact, last night one of our colleagues called up from Mangalore and asked, there is this publication I'm going to do in the Journal Club, which actually says that submucous fibrosis is not a potentially malignant condition. It's got a lot of good effects and we should market it. These are dangerous statements because there is enough scientific evidence to show that yes, it has got some good effects on the central nervous system. It creates euphoria. On the other hand, you may not live long enough to enjoy those benefits because you'll develop cancer. So you need to be careful about that.
Thank you so much, sir. I think a lot of things were cleared with sir's. Anybody on any thoughts from our panelists online on the same? Prof. Tilak, Raghu or Karishma? Yes. No, sir. So then I go ahead with our next panelist, Dr. Raghu. Raghu has been doing quite the next generation working on this, especially in the genetic and molecular aspect of it. And so the basic questions which we have tried to compile with Raghu is very important. Why are certain cohorts specifically susceptible to to oral submucous fibrosis? What could be the rationale behind it, like disease prevalence being lesser than the population with habit, or the population having the habit of chewing areca nut? Secondly, in relation to that, what are the various genetic variants or polymorphisms that have been, because in continuation with the susceptibility, making it increasingly susceptible to oral submucous fibrosis? Have they, in continuation with Dr. Jainta, any specific dietary habits have been associated as risk factors, and whether the use or the presentation of oral submucous between the traditional and newer alternatives like smokeless tobacco or e-cigarettes, are there any difference or it's the same? Are there any synergistic effects of alcohol? Sir was telling on slake line, whether, since we are talking more on the polymorphism, the alcohol role could be having a role in the risk of developing OSMF or in the transition part to oral squamous cell carcinoma. All yours, Raghu.
you, Dr. Pratibha. It's always a pleasure meeting you in any scientific fora. And I have with me the doyens of oral submucous fibrosis, Dr. Tilak, Dr. Ranga, and Dr. Hazare. It's just a humble attempt at explaining some of the things that we already know. And I'm sorry I don't have a presentation because I wasn't really sure of the format of this panel discussion. I was of the opinion that it was questions and answers. So what I would do is address each one of the question that Dr. Pratibha has just raised, which is obviously pertinent. And the first thing was, why are certain cohorts specifically susceptible to submucous fibrosis? We know that the prevalence of submucous fibrosis, it varies across cohorts. Certain cohorts are specifically susceptible to submucous fibrosis due to a combination of genetic, environmental, cultural, and the lifestyle factors. OSF clusters in families, and that suggests a hereditary component, and it was, I think, Dr. Rajendran way back in 2004 published this report. And then in 1986, even before Dr. Rajendran published that the OSF clusters in families, Pranif published this very important piece of information on the genetic variants, where some of the HLAs, like the HLA and the HLA-DR3 and the HLA-DR7, are more common in individuals with oral submucous fibrosis, which suggests a genetic susceptibility. So we have now seen that there are polymorphisms in some of the cytokines. We see there is variant in the TGF-beta1, the interleukin-6, the tumor necrosis factor alpha, which are all the pro-inflammatory cytokines, and this can influence the inflammation and fibrosis. Another important piece of information that we have is about some of the enzymes which are involved in the detoxification process. So the genes like the GSTM1, the GSTT2, and the CYP1A1 affect the body's ability to detoxify some of the harmful substances from areca and tobacco, making some individuals more vulnerable than others. And these are some of the factors which has some evidences leaning towards the genetic predisposition. About the cultural and the lifestyle practices itself. The habit of chewing areca nut is deeply ingrained in certain cultures, particularly in South Asia, Southeast Asia, and the Pacific Islands. This is one of the primary risk factors for submucous fibrosis. And when we talk about the lifestyle practices, we also mention the combined use of tobacco and alcohol, which again increases the risk of submucous fibrosis and accelerates the progression of the condition. And then we cannot ignore the fact that submucous fibrosis is more commonly seen amongst the lower socioeconomic strata. And much of this could be attributed to the limited access to healthcare and education about the risk of areca nut. And the reason why there is a higher prevalence of submucous fibrosis amongst the socioeconomic, the lower socioeconomic strata. So combining all of these factors together, I mean, we can conclude that the genetic variants affect the collagen metabolism. It brings about the immune dysregulation. Some of the cultural practices like areca nut chewing and the tobacco use independently as well as in a combination also increases the risk. And some of the environmental and socio-economic factors also increase the risk of submucous fibrosis. So that's the reason that certain cohorts are more susceptible than others. And the second question that was raised was what genetic variants or polymorphisms are associated with an increased susceptibility of oral submucous fibrosis. So, oral submucous fibrosis, for the benefit of some of the students who are there, is a multifactorial disease with both environmental and the genetic factors contributing to pathogenesis. Several genetic variants and polymorphisms have been associated with increased susceptibility to submucous fibrosis. These factors involve genes which are related to inflammation, fibrosis, and the detoxification processes. Let us look at some of those genes which are associated with inflammation. The first are the cytokines, which are the pro-inflammatory markers. So the polymorphism in the transforming growth factor beta, which is central to the pathogenesis of submucous fibrosis, has been associated with increased fibrosis. And we all know that TGF-beta is a key cytokine that is involved in the fibrosis. The second thing is the inflammatory cytokines like the interleukin-6 has also been, the variations in the interleukin-6 and the polymorphisms associated with interleukin-6 have also been linked to the increased susceptibility of submucous fibrosis. The polymorphism in tumor necrosis factor alpha are associated with altered inflammatory responses and thereby increasing the susceptibility to submucous fibrosis. So these are all some of the polymorphism in the inflammatory cytokines. Then let's look at some of the polymorphisms associated with the matrix metalloproteinases and the tissue inhibitors of the matrix metalloproteinases. They're basically the molecules which affect the degradation of the extracellular components. And an imbalance between those which are the ones which are proteases and the others which are the inhibitors of these proteases can also contribute to excessive fibrosis. Let's look at the other enzymes which are involved in the detoxification processes. Cytochrome P450 enzymes. So these are a group of enzymes that are found in the liver and perform the oxidation, the reduction reactions using iron. So two of the commonly studied polymorphisms of the cytochrome P450 enzymes are the CYP1A1 and the CYP2E1. The polymorphism in CYP1A1 gene is involved in the metabolism of the areca nut alkaloids. And CYP1A1 may function as a carcinogen detoxification enzyme, and any polymorphism in CYP1A1 can contribute to the pathogenesis of submucous fibrosis. And another important cytochrome P450 enzyme is the CYP2E1, which can again affect the detoxification process of areca nut components, potentially increasing the risk of submucous fibrosis. The other enzyme which is involved in the phase 2 detoxification is mainly found in the cytosol, and this is the glutathione S transferase. So the polymorphism in the glutathione S transferase M1 and GST-T1 also can contribute to the pathogenesis. So these are all some of the commonly studied polymorphism, but I think recently we published a paper in the oral diseases where we have spoken about the polymorphisms in some of the microRNAs. Two of the more commonly studied microRNAs are the microRNA 146A and MIR499. So variants in these microRNAs which regulate the expression post-transcriptionally have also been associated with increased susceptibility to submucous fibrosis. And another important piece of work which Dr. J. Gopal Ray has published related to the polymorphism in some of the genes related to the DNA repair are the XRCC1 and the XRCC3, because these polymorphisms actually impair the DNA repair mechanism and thereby increasing the mutation risk and thus contributing to submucous fibrosis. So these are some of the factors and some of the variants in the genetic polymorphism which necessarily is the reason why there are certain cohorts which are more susceptible than others. Anything else that I have to add, Dr. Pratibha, at this juncture?
Yeah, I think it suffices, but just on a point of it, like we had one, just summing up probably Raghu in this aspect, we actually had one, this was a patient, I think sir will remember, we had a young boy, he was just 6 or 7 years old, and he had reported with oral submucous fibrosis to our hospital, and we were just wondering as to how this boy developed oral submucous fibrosis. But of course, as always, we know that teachers have taught it, very important is taking family history. So on taking a family history, this boy, they come from the Saukarpet area, which is typically a Hindi belt area of our city, and he has the habit of, right from his childhood, like 2 or 3 years, right from he used to take the areca nut in the very prepared forms and used to give his grandparents and parents, because I think they have the marriage, they have their father maybe 30, the grandfather maybe 50. So every time the child used to go, he used to have one in his, part of it probably in his mouth, and he used to then give. But the thing was, the other two, the grandfather nor the father, had any signs of oral submucous fibrosis. But this child has developed. Do you think, what could be the actual factor here? With so much of mechanisms we have been thinking around, there has been a strong background of genetics. I think they have been having for past 30 or 40 years, but only this child has developed a classical submucous fibrosis. Your thought on this?
I can only think of two things at this juncture. One is the xenobiotic metabolism. And then the second thing is the endobiotic metabolism. Two of the genes that I was just mentioning in the cytochrome P450 enzyme class are the CYP1A1 and the CYP2E1. So basically the CYP2E1 catalyzes the oxidation of variety of these endobiotics. And when I talk about the endobiotics, I'm talking about the retinoids and the prostaglandins. And then we also have to talk about the metabolism of some of these xenobiotics, because these are all some of the drugs which are not endogenous to the system. So, if there is a polymorphism of these genes, some of these compounds are probably not metabolized and thereby actually predisposes some of these younger individuals to submucous fibrosis than the others. So I think it's important for us to actually look at the polymorphism of some of these genes in the cytochrome P450 enzyme class.
So do you think when we have patients who report to our or just do a population survey and check for as a preventive measure, like as you are suggesting, could this be an ideal indicator? Like we know that areca nut chewing is prevalent pretty much across. So do you think this could what can I say, the markers which you have suggested, if could have a hope or could have an implication to suggest if the individual is susceptible to oral submucous fibrosis if a habit is there?
So I think to explain it or to summarize what I have just said, identifying these genetic variants definitely can help in assessing the risk of developing submucous fibrosis. One. And today, we have been talking about the personalized medicine. So I think it becomes all the more important to understand the genetic basis of submucous fibrosis, which can lead to more targeted therapies. So the best way to do that is genetic screening. So that way, you could have early intervention, and some of these preventive measures in the high-risk population could be thought about. So there are, of course, multiple genetic variants and polymorphisms in genes which are related to inflammation, fibrosis, and detoxification processes. So I think some of these genetic factors which are combined with the environmental triggers like the areca nut chewing can definitely contribute to the pathogenesis of the disease. So I would just put the two together and then say that it's also important for those who are exposed to the habit, what is their genetic makeup, if there are any altered metabolic pathways, if there are any known polymorphisms that they have. So, and that way I think, you can facilitate early intervention.
Thank you, Raghu. I think that was pretty exhaustive reply which you have given. I think Professor Hazare has something to add on.
Thank you, Ravi. Thank you, Raghu, for wonderful topics on OSMF and the wonderful studies your institute has done. And since this is a consensus meeting, I would like to add that in treatment protocol, surgery also plays an important role. I have seen a 4-year child. Similarly, his grandparents and parents used to give areca nut taken out from the gutka, and that contained high alkaloids, which were pleasure poisons. And over constantly using for a couple of months, he developed submucous fibrosis at the age of 4. He has only 10 millimeter of opening. He was followed up. He, of course, stopped chewing, and in his family history, there was a cancer and a death also. So genetic studies are to be done, definitely. But when he grew up, one thing is important, you should have a strong follow-up. We motivated him for areca nut cessation. He quit the habit, and of course, when he joined almost after 17 years, I have seen him. So at the age of 21, when he was attending the college, still 10 millimeter of opening was there. So we decided to let it go for surgery, and nasoalveolar surgery, flap surgery has done wonderful opening for 30 millimeter. So in treatment protocol, add a surgical arm. Besides what Professor Raghu has said, personalized medicine. I'm sure I was talking about oral metronomics chemotherapy, and Professor Raghu's institute has studied 7 cases and all the submucous fibrosis cases or PVL cases, and they were COX-2 positive. So there is a role of COX-2 inhibitors. That's what I was talking in oral metronomics chemotherapy. Thank you, Raghu, for that wonderful study from your institute, explaining the personalized medicine and especially the role of oral metronomics chemotherapy. In last conference at Malaysia, I think this topic was widely discussed. Anand, in last Kuala Lumpur meeting, Pratibha was there, and she can brief the importance of oral metronomics chemotherapy.
Sir, actually I am not a, I don't practice, but I've heard you speaking on this and the success rate. I think you had 3 or 4 cases of follow-up cases, and I remember the same, and I think a person's practicing here is sir, and he's been following up the patient. I remember 3 or 4 patients I think sir had shown us. So maybe I think Hazare sir would be the best person. In the question and answer session, maybe sir can follow it up. Anybody else has anything else to add on to what Professor Raghu has just mentioned, or I go ahead with Dr. Punya. Next is Professor Dr. Punya. She's also been doing a lot of work with regard to this particular aspect and has got a number of questions. So as far as Punya was part of it, we just wanted to focus more on the pathogenesis aspect of it, not describing the entire pathogenesis, but very specifically we just wanted to know a simple consensus on what could be the plausible mechanism which could help in the treatment aspect of it, and whether we had wanted her to check what would be the role of these, because we always think oral submucous fibrosis to be associated with the connective tissue. We talk histologically about a lot of hyalinization, and epithelium is always a neglected part, considering that, of course, now since we are getting to see more of oral OSCC and PVLs, we are having an impact on the epithelium, but definitely we know there is an interplay of fibroblast and epithelium, and along with vasculature and immune cells in the pathogenesis. And Raghu has briefly told about the biomarkers. I think she will also touch on the same. And what was most important, 2 things which we wanted her to see was why only certain areas, like we always know a buccal mucosa or is most commonly affected, or labial mucosa is affected, unlike a gingiva or a PDL, which there are few studies, but not much. They have done some assays or something like that. But clinically, apart from the loss of the stippling and all, there is no clinical manifestation of the disease. And we know that the PDL seems to get stronger, probably because of the collagen. So what is it? What could be the difference in the pathogenesis? Though areca nut chewing is involving the entire mouth, only certain areas there is propensity and other areas are not as much affected. And this molecular, and ultimately whether this molecular is having an effect on the treatment. Thank you, Punya.
At the outset, I would like to thank the organizing team of this conference, especially Dr. Pratibha and Dr. Ramya for inviting me for this particular symposium. My humble greetings to all the senior oral pathologists and seniors present here, and all the panelists who are present here. So I'll be presenting on the... Changing. I'll use this. Sorry. I'll be presenting on the molecular pathogenesis of oral submucous fibrosis, taking into consideration the questions that Dr. Pratibha has mentioned previously. So over 5 decades since it was discovered in 1952, the pathogenesis still remains controversial. So it's multifactorial in etiology, as it has been previously mentioned by the panelists. So there is a genetic predisposition. Pointer, okay. Not working, okay. The genetic predisposition. Oh, okay. And there are a lot of studies which have shown that metabolic and nutritional deficiencies also play a role, especially with relation to copper. But there is consensus for today's consensus meeting. We have a consensus that areca nut is the cause. It causes oral submucous fibrosis, biochemical and mechanical irritation. As Dr. Jayanta has pointed out, it is available as processed and non-processed forms, and along with tobacco, it has a synergistic effect. Okay, so the areca nut has metabolites which includes alkaloids, flavonoids and tannins, and the most potent among them is arecolin. And we all know oral submucous fibrosis is a fibrotic disorder, so there is fibrosis and it's also a potentially malignant disorder in the sense that it can result in cancer. So arecolin has been implicated for the fibrosis, which is because of these two things, that is there is increased collagen synthesis and there is decreased collagen degradation. So this is, firstly it is mainly activating the fibroblasts. So the arecolin and the alkaloids associated with it are activating the fibroblasts. So it could be because of the mechanical irritation, that is the crude fibers may cause discontinuity or discrepancy in the overlying epithelium, and you find that the alkaloids can seep into the connective tissue and activate the fibroblast. That is, they elicit inflammatory reaction, and there is release of numerous cytokines. Among them, we now definitely know that TGF-beta is the key cytokine in the pathogenesis of oral submucous fibrosis. Okay, so the TGF-beta has a role in both increasing the collagen production as well as decreasing the collagen degradation by various mechanisms. I am not going to go into detail, but TGF-beta has been known to stimulate the collagen genes. It is also stimulates the collagen cross-linking. It also activates the tissue inhibitor matrix metalloproteinases, so there is decrease in the MMP activity, as well as there is a vascular malformation in the sense plasminogen inactivators, inhibitors are also activated and ultimately resulting in decrease in collagen degradation. But the most important role which is now identified for TGF-beta is this is one of the systematic reviews which we have done in our institute, and we have shown that TGF-beta acts by various pathways. You have both the canonical as well as the non-canonical pathways which are playing a role in the fibrosis through various mechanisms, that is by stimulating inflammation, increasing the fibroblast proliferation, reducing the apoptosis, producing cellular senescence, and also affecting the angiogenesis. And the most important role that TGF-beta has is it causes transdifferentiation of the fibroblasts to myofibroblasts. So myofibroblasts have now been identified as the key cells in the pathogenesis of oral submucous fibrosis. So myofibroblastic phenotype usually stimulates the abnormal tissue repair, and they are considered to be immune privileged cells in the sense they can escape inflammation and continue to proliferate, and they produce a lot of extracellular matrix. And it's also considered to be related to the mechanical strain which is associated with the oral submucous fibrosis that causes the scarring as well as the tissue fibrosis. So this is about fibrosis and the pathogenesis, that is the fibroblast activation. So that was my first question. The consensus is areca nut is the cause. The second consensus is TGF-beta is the cause or the cytokine which is most commonly involved, and the TGF-beta, the key mechanism is transdifferentiation of fibroblasts to a myofibroblast. So that is about fibroblasts. So what is the role of the other components which are present in the connective tissue? You have the overlying epithelium which shows atrophy, and you have submucous compartment which consists of vessels, immune cells. So what is their role? So now we know the epithelial cells are getting damaged because of the mechanical irritation, and we also know that arecolin is genotoxic. It also has a toxic effect on the keratinocytes, so it can result in cell cycle arrest and apoptosis, and also causes release of reactive oxygen species. Of late, we have the epithelial mesenchymal transition, which is being considered to be an important mechanism in the fibrosis. So what happens in epithelial mesenchymal transition is the epithelial cells, they lose their morphology and they lose the markers which identify them as epithelial cells and their polarization, and they are converted into mesenchymal cells. So mesenchymal cells are nothing but your fibroblasts and myofibroblasts. So they could be actually epithelial cells which are undergoing transformation to form fibroblasts and myofibroblasts. So the epithelial cells may play a role in release of reactive oxygen species. They also have a role in EMT. So this is a study which we have conducted where we have shown that there is reduced expression of E-cadherin and beta-catenin and enhanced expression of N-cadherin, vimentin, fibronectin, which shows that EMT is present in oral submucous fibrosis. EMT also has a role in transdifferentiation of the fibroblasts to myofibroblasts. So again, oral submucous fibrosis, because there are a lot of myofibroblasts which are present, has been considered to be a altered wound healing pathogenesis. So that it is a sort of a altered wound healing which is happening here because of the irritation, which is chemical and mechanical irritation of the areca is stimulating an altered wound healing, and due to which you are getting fibrosis. So what about the submucosal vasculature which is present around? So there are, as we see the disease increases and you go to the advanced stage, the number of blood vessels are decreased and they become obliterated. And this stimulates a hypoxic reaction, that is you have HIF1 alpha which comes into play, and HIF1 alpha again activates the downstream cytokines, which is most commonly the TGF beta. It also inhibits the proliferation of the endothelial cells, and that results in release of reactive oxygen species. It promotes inflammation by altering the adhesion profile of the endothelial cells. So the endothelial cells will will show certain changes in the adhesion, due to which you find that there is more amount of inflammation which can occur there, and the endothelial cells may also undergo changes to form mesenchymal cells, which is referred to as the endothelial mesenchymal transition. And other than that, it can also cause some vascular abnormalities, that is the fibrinolytic activity will be decreased by release of plasminogen inhibitors. So all of these changes which are occurring in the submucosal compartment are specifically affecting the vessels. It will cause epithelial atrophy and again predispose for fibrosis. And again, as many of you have already mentioned in the panel, that the oxidative stress plays a very important role in the pathogenesis of oral submucous fibrosis. So the oxidative stress has been implicated for resulting in damage of epithelial cells. Oxidative stress stimulates increased cytokines. It has a role in cellular senescence, and again it has a role in EMT. So that can result in fibrosis. There are two new concepts which have also been mentioned in several recent studies. One is autophagy and another is role of the microbiota which is present in the oral cavity. So autophagy is basically a mechanism by which you find that the dead and damaged cells are reused as biomolecules or recycled, and autophagic mechanism downstream cytokine again is TGF beta. Okay? And also autophagy has been shown to increase the myofibroblast differentiation, which in turn produces increased collagen production. And the microbiota which is being studied in oral submucous fibrosis patients have shown that arecolin does disturb the microbial flora, and there is dysbiosis of oral microbes, and there are certain microbes which are increased and certain decreased in oral submucous fibrosis. So these mechanisms have also been implicated for development and progression of OSMF as well as its malignant transformation. So that answers my second question, that is the interplay of the fibroblasts with the epithelial cells. Just to summarize the same, so this is the epithelium. It gets damaged because of the arecolin and also because of the reactive oxygen species that are produced, and it causes cell cycle arrest and apoptosis. The epithelial cells can undergo atrophy secondary to these changes, and also it triggers the fibroblast to differentiate into myofibroblast via EMT. Okay, and here you have the fibroblast being activated by the inflammatory cells. You have TGF beta coming there, and the fibroblast again proliferating and giving rise to extracellular matrix. The fibroblasts by themselves can also undergo changes to myofibroblast. You have the vessels here which are undergoing injury and they are releasing basic fibroblast growth factors. They also have increased viscosity. They may have a role in autophagy, and all of that can also result in endothelial mesenchymal transition, giving rise to myofibroblasts. So the key cytokine here is TGF beta, and the key change that is resulting in a lot of fibrosis which is evident in oral submucous fibrosis is the inflammatory component along with the transdifferentiation of the fibroblasts to myofibroblast. And there have been a lot of biomarkers studied in OSMF. It has been in the cells, it has been in the tissues, it has been in the serum, it's been in saliva. There are a lot of studies which are available, but there is no single marker which can be used for clinical purpose, either for staging of oral submucous fibrosis or for predicting the malignant transformation. Of course, there have been a lot of studies which are still going, but there are no longitudinal studies which have actually seen the efficacy of these particular markers, and definitely that could be a point of research where we need to do high quality standardized studies which could be then applied for clinical application. The next question was the site-specific changes. So what we see in oral submucous fibrosis is we have a person eating areca quid or areca nut, and they are usually placing it in one place, which could have actually given rise to a leukoplakia or a tobacco pouch keratosis in that place, but it's giving rise to a generalized condition. So there is multiple site involvement which is seen in oral submucous fibrosis, and it's usually classified as a condition rather than a lesion. So Dr. Arikeri has come up with a concept called as salivary pooling. So salivary pooling is pooling of saliva in certain surfaces where you find that there is increased pressure of these and increased pressure and high concentration of Gutka ingredients which will be there in that particular area. And this permeability of these alkaloids or the toxic components of the areca nut and depends upon the permeability and the absorptive capacity of the oral mucosa, which in turn depends upon the thickness and degree of keratinization. So as we know, the sublingual is the least, is the most susceptible, then you have the buccal mucosa, and then the palate because it is keratinized. And I'll go further saying that gingiva and periodontal ligament are least affected. So what they say, according to their study, is there is excessive pooling in the buccal mucosa because that is less susceptible and less permeable. So it's a favorable route and the most vulnerable site and the most convenient site to place the Gutka, and that is the area which gets affected first. So it's usually the posterior most area of the buccal mucosa which gets affected, and once it is fibrosed, then there is no pathway for the Gutka ingredients to pass through, then it's subsequently spreads on to the other parts of the oral cavity. And gingiva and periodontal ligament, can they evade OSMF was the question. There are a lot of studies which have been done and they are less susceptible, definitely less susceptible compared to buccal mucosa and other parts of the oral cavity. Compared to them, gingiva and periodontal ligaments are less susceptible due to various reasons. The first and foremost, the repair that happens in gingival fibroblast has been compared to fetal healing or fetal repair, because here you have more amount of matrix metalloproteinases, and the extracellular matrix remodeling which is occurring is comparatively different than that which is happening in buccal mucosa. So you have a more pronounced extracellular matrix remodeling here, and the type of collagen that is produced is predominantly type 3 collagen, which is considered to be fibrillar and fine as compared to your type 1 collagen. And there is a lot of vascularity present in the gingiva, so they are resistant to the hypoxic changes that are predisposed to fibrosis in case of oral submucous fibrosis, and they are considered to be immune modulatory in the sense that they usually have a short inflammatory response and they do not have inflammatory response for a long time. This is because they are already always exposed to inflammation, because there is always microbiota, there is always plaque which is present in the gingiva, so they are used to this sort of inflammatory response and do not hyper-react like how you have in the buccal mucosa. And the gingival fibroblasts are thought to have a very dynamic phenotype, and they are adaptable to, and they are not much exposed to the mechanical strain which has been implicated for myofibroblast transdifferentiation, because they are already exposed to masticatory stresses. So they resist the excessive myofibroblast transdifferentiation, and that is not very commonly seen in case of gingival fibroblasts. And what we have in gingiva is presence of gingival mesenchymal stem cells. So these cells are pluripotent and they are present in the gingiva, and they have a enhanced regenerative capability or regenerative potential. So they also help in enhancing the wound healing, and they do not go or fall into the fibrotic wound healing phase or cycle. So these are the reasons why gingiva and periodontal ligament might evade OSMF. I can ask Pratibha if she knows any others, any other points which could, it was a very nice question and really made me think of this, because not many studies are there which have actually touched on this particular topic, but definitely the gingiva and periodontal ligament have shown very less features as compared to your buccal mucosa or the other parts of the oral cavity. So have these molecular pathogenesis applied for the treatment? Yes, definitely they have been applied, but there is no unified therapy. There are multiple pathogenesis and there is multiple therapies related to that. So for the modulation of the extracellular matrix, there has been use of hyaluronase, collagenase and chymotrypsin injections, which basically targets the extracellular matrix deposition. So they are trying to break down the collagen there and trying to bring about degradation. For regulation of the inflammatory response, which is further triggering the downstream fibrosis, we have steroids, interferon gamma, colchicine, which have been used, which will prevent the proliferation of the fibroblasts and reduce the activation of myofibroblast. In order to ameliorate the peripheral microvascular disturbance, you have pentoxifylline and ninhydrin hydrochloride, which have been tried in even T pigments. And for the reactive oxygen species, we have antioxidants targeting the TGF-beta pathway. We have curcumin. The EMT pathway, we have dental pulse stem cells. We also have done a recent study on dental pulse stem cells, and they are quite effective in overcoming the changes which are seen with relation to EMT. And then you have those which are targeting the angiogenesis. I think that answers most of the question. Yeah. Anything else?
Thank you so much, Punya. I think that was very comprehensive, touching something which is very difficult. You have made very simplified. And actually thank to their team, because we had a symposium in IOMP that they had given me this topic on stem cells. So as I was going through that, this idea of the gingival stem cells was because it has a dual role. Stem cells can be a killer or it can be a curer. So in that aspect, when I was going through the literature, this idea of why they are trying to use of dental stem cells and the mesenchymal derived stem cells from gingiva had popped up, and on going through that, yeah, it then stuck to me. Yes, most of the time we keep reading only other parts of the oral cavity, but never, very less is taught about gingiva. And
we should harness the gingival mesenchymal stem cells for treatment subsequently. And I saw that you have already published that, so congratulations.
I think, the most important thing I think, which was touched on, which you had covered, do you think whichever the treatment or the pathogenesis has a simulation to the idiopathic lung disorder or the cirrhosis, or wherever there is excessive amount of fibrosis is there, many of our mechanism is related to that. As you said, where there is type 1 collagen, the propensity seems to be more than in type 3. So almost the entire area where a TGF-beta can touch is predominantly on this type 1 collagen. So the treatment part of it which you had described, and I think sir had also mentioned, do you think those drugs which are already approved can have an effective role in the initial stages of oral submucous fibrosis? Because as it gets advanced, we can never revert it back.
True, that could be done actually, but with regards to idiopathic lung fibrosis, there the epithelial cells are undergoing changes. Here it is predominantly a fibroblastic disorder. But definitely those drugs which are targeting the fibroblast to myofibroblast change, there are several which are available. So they definitely could be studied.
Anything to add, sir? Okay. I think, thank you so much, Punya. And now we go to yes, sir. Yes.
Now in treatment options, of course, stem cells have shown a very good promise by Dr. Supriya Keur Pandey from D.Y. Patil. She spoke last at our conference in Kodaikanal. It's convincing. So research on stem cells, especially pulp-derived mesenchymal stem cells, is required. And that can go as one of the recommendations.
Just one word of caution to that, it's always nice to talk about stem cells. We're having one next week actually, talking about it. Like, I think you made a mention of it. It's a double-edged sword. You need to understand that stem cells will differentiate depending upon the environment. If you don't change the environment and you put stem cells there, you may get cancer as quickly as you can get submucous fibrosis, potentially. So please to understand that stem cells work only as much as what the environment and they are. And unfortunately in submucous fibrosis, that is the problem. Just one more thing actually, I thought I'll sum it up, but because stem cells came up, so it's a very good point actually. It can be used definitely, but with caution. Is the point that the fibroblasts are mutated. So that is why surgery doesn't work. Because even if you put a new fibroblast, because the environment is different, they don't form new collagen. And there is another flip side to this is because fibroblast is very unique in that it produces collagen and resorbs collagen also. It does both the jobs. You don't have osteoclast and osteoclast. You don't have a fibroclast. So unless you remove it and put a fibroblast which is not mutated, that's why it's irreversible. Basically, submucous fibrosis is irreversible. The classic example I can give you is, you look at, you touch an animal, the leather is very soft and supple. But look at your purse and things out of which leather is made. Do you think any treatment is going to shift it back to that? So and that's why when Dr. Punya was talking, I don't know how many of you noticed, they have flavonoids and tannins. Tannins are what they use in leather industry to actually make your mucosa very stiff. So those things also contribute significantly to the stiffness of the mucosa. Quickly.
Thank you so much, sir, for adding on the double-edged sword aspect of stem cells. Moving on, I think next speaker is almost like synonymous. Most of us know about in oral potentially malignant disorders. He and Professor Saman have done quite a bit of work, and now I think sir's focus is shifted on to one interesting aspect is which we have also been working as to how we are getting to see a lot of oral squamous cell carcinomas in oral submucous fibrosis. Yes, the prevalence and incidence differs from region to region. But what is the most interesting aspect which we have also studied is that somebody had told, as Professor Ranganathan sir had told, it is OSMF is actually doing good. I am sure surgeons also agree. Many times the squamous cell carcinomas which when surgery done in oral submucous fibrosis seems to be low grade. And we find that there is no node involvement. Absolutely, it seems to be superficial. Probably the reason being the fibrosis aspect of it. Though it changes into a C, and it's a very interesting part which has been studying, and whether we should have a different staging, because our surgeon, once they operate on a OSCC in an OSMF patient, the entire staging itself changes, and our grading in as far as histopathology and staging in histopathology also changes, because invariably, very rarely we get to see an aggressive or a moderately differentiated squamous cell carcinoma, and many times there are no nodal involvement, and it's very difficult for us to guide the surgeon as to whether they should go in for the radical neck. So in that aspect, I think the best person to clarify on this would be Prof. Tilak Ratne. So what is the current understanding of the relationship between OSMF and the incidence and prevalence of OSCC? Should it be considered as a separate type of oral squamous cell carcinoma due to its different behavior? Are there any specific histological features in oral submucous that can predict that it can become an OSCC? And as I had mentioned, does this type of OSCC in OSMF require separate grading and staging? Thank you so much, Prof. Thank you so much.
Thank you, Dr. Pratibha. First of all, let me thank the organizers for inviting me to share our ideas on this deadly disease. Well, I have been listening to few speakers now and I think the audience has got a lot of knowledge in different aspects. Am I audible? Am I audible? Right. Okay. I start? Right. Now, we are here discussing one of the commonest diseases in the mankind, right? So, we may or may not have realized that. If you look at the reality, now recent data suggests us oral submucous fibrosis is the commonest OPMD in the world, even a little more than leukoplakia. So, however, although this disease we all know was described in 1952, until recently, WHO did not focus much on this disease. In fact, we did not have a separate section for oral submucous fibrosis in the WHO Blue Book. It is only this time that we managed to include one section, significant section on oral submucous fibrosis. Thanks to Ranga and Saman, after our invitation, you both did a wonderful job. And so that was the problem basically. We all question why there is no proper treatment for oral submucous fibrosis. Simply because we did not have hard science on various aspects of submucous fibrosis. In fact, our friends in the West, in Americas, they didn't know much about this disease. I think we tried our best to popularize it in that part of the world. I think those who have not read, I think you should read the 2016 August issue of Triple O, where we produced a focused issue on oral submucous fibrosis. After that, I realized a lot of our friends in the West and also in Americas have some interest towards this disease. Right. So now the reality is a lot of people know about this disease, right? So therefore my request to young researchers, I'm not going to give you a very hard scientific talk because you already had. You should use the opportunities, your networking collaboration to get people from the developed part of the world to work on oral submucous fibrosis like we did with Japanese, Korean, Chinese and also UK teams. So, of course now we have enough research facilities in our part of the world, but still it is better to popularize the research coming from submucous fibrosis around the globe. Now, no meaning of telling every lecture all the time we don't have a treatment, right? So, we should think this very seriously. We are not talking about a complicated disease. Right? We are talking about a chronic inflammatory disease, the commonest pathophysiological disease, the process in the human body. Most of other chronic inflammatory diseases have definite treatment, but we don't have. Now, as previous speaker said, a lot of epithelial changes and also connected to changes in this disease. We also, when we were young researchers, now mind you, my very first research about 30 plus years ago was gradient dysplasia in submucous fibrosis. That was my very first research. So over the years we used to think this is a connective tissue disease. But we have, as well as others have shown, this is actually epithelium driven connective tissue disease. First signals come from the epithelium into the cells in the connective tissue, upregulation of TGF, beta, etc. So the disease, I think we know ample about pathogenesis and even the mechanisms of malignant transformations. What is missing is we have not targeted those molecules and gone into the next step of targeting some of these molecules in order to get some translational value from some of these top class research. Now, if you look at the OSF malignant transformation rate, it varies a lot, right? Because the studies that we have are very, very heterogeneous. Now, few studies that we use for the WHO classification this time, one was the Omakujan and Saman's the systematic review, where they mentioned about 4% is the transmission. But again, the papers are very heterogeneous, leading to a lot of bias. And they have clearly said that cases with higher grades of dysplasia have a high chance of transmission. That's a reality that we all know. And also another very good review came a few years ago again from Ayaka et al. Now in that review they talk about, they have measured all the malignant transmission rate both annual and overall in all the OPMDs. That is where we got information that lichenoid lesions have a higher transmission rate than lichen planus. In that they say OSF has 5.2%. I think that is the correct rate, perhaps around 5%. That we need to remember. And also another question that we always we don't look at from that point of view. What is the evidence of oral submucous fibrosis in the cancer excisions that we see? To answer that question, we looked at a huge sample of oral squamous cell carcinoma, not in Malaysia, while I was in Sri Lanka. So in that cohort, almost 1,000 cases, I guess, if I remember, 48% of them had some form of, or some degree of submucous fibrosis. Whether that submucous fibrosis is just side by side or the cancer is a different thing, we don't know. So those are areas where we need some research. But the real fact that we need to understand is in our part of the world, the large majority of cancers occur, oral cancers occur in the background of submucous fibrosis. And there was a very interesting conference in Taiwan where I was the keynote speaker a couple of months back on betel quid related oral cancer. And the topic given to me was, is betel quid related cancer is different from the rest? The answer is, my answer is a simple yes. Because most of our cancers occur in the background of submucous fibrosis, as Pratibha correctly said, raises some of the points. Now, the metastatic rate is less. All know, those who are pathologists looking under the microscope day in, day out about submucous fibrosis, we know the extracellular matrix, which is the most important component when a cancer finds its own way to a lymph node. But it's not rocket science. We can simply understand hugely hyalinized stroma will not allow these cancer cells to move very easily, finding a lymphatic or a blood vessel. Now we all know the supporting factors are there as well. The collagen we have in submucous fibrosis is not normal. As somebody correctly said, the type 3 collagen converts into collagen type 1, and even that collagen, we know the problem in submucous fibrosis is the lack of homeostasis between collagen production and collagen degradation, right? So even the little amount of collagenases we have cannot break the collagen that is present because it is abnormal. We know after someone's work with Trivedi et al., there is abnormal cross-linkage. So even the little amount of MMPs we have perhaps cannot break that collagenous matrix. So cells are finding very difficult. There are various other ways. Remember, hundreds of various other molecules, pathways, etc. are regulated, down-regulated in submucous fibrosis. But these cells are finding very difficult to move in the extracellular matrix to find a blood vessel or a lymphatic to go into a lymph node. So that is probably the very reason why there is less metastatic rate. In relation to that, there is another thing. Our good friend Dr. Vinay Hasare knows, and he is very interested in this area. The development of verrucopapillary lesions in the background of submucous fibrosis. Now, another area where we don't have enough good research because we all know the epithelium of submucous fibrosis after some time, in some cases, tend to be transformed into malignancy. But due to the factors that I said earlier, these cells finding it difficult to penetrate the extracellular matrix to show us the hallmark feature of cancer, the invasion. But this epithelium is, these in very general terms, right? But our young researchers should embark on these things. But the epithelium is to inform malignancy, altering all the various pathways, mutated various cancer-related genes on suppressor and oncogenes. But this epithelium needs to go somewhere, right? That probably the reason why they go exophytic, right? But these areas need more research. But in short, I feel the oral squamous cell carcinoma that we see in our part of the world is a different disease, and it should be treated differently, and the prognostic indicators that we talk about and we are getting from the West may not be applicable to our patients. So therefore, there is a dire need for you all to come up with our own treatment protocols using our clinical audit data and also the research data. So that's very important. Now another question that I think she asked, are there any histopathological features to predict this particular OSF case transforming into malignancy? The simple answer to that is 100% proven features we do not have, but we have, as we all know, various histopathological features which can predict malignant transformation, whether there is submucous fibrosis or not. The dysplasia, irrespective of we are living in the molecular world, degree of dysplasia is the most reliable feature, histopathological features to predict any OPMD transforming into malignancy. There is no difference in submucous fibrosis, that's true. Degree of dysplasia has a direct relationship with malignant transformation. But where there are other features in submucous fibrosis, if you look at the fibrosis, degree of fibrosis, right, may have a role in malignant transformation. We have shown in a couple of papers that thickness of fibrosis and degree of dysplasia has a relationship. Right? The higher the degree of the fibrosis, more the degree of dysplasia. So that is a reality. We have shown that convincingly, and also hello, am I audible? I'm sorry, I have a message saying that you didn't hear what I said.
The last part from dysplasia, we were not able to hear you, sir.
Right, okay. Ramya is calling me. Yes, Ramya? Right. I think the last part that I was talking about is the features that can predict the possible malignant transformation of a given case. I said the degree of dysplasia is the most important. I hope that part you heard. And the degree of fibrosis. Higher the fibrosis, more the dysplasia. That is something that we have shown. I said that. I don't know whether you heard or not. And when there is fibrosis, we know the tissue starts suffering from hypoxia. Then there is a whole lot of various molecules upregulated in the background of hypoxia in order to maintain the survival of cells. And upregulation or overexpression of those molecules, genes, can increase the survival and increase the proliferation of cells. That can lead to higher grades of dysplasia and of course malignant transmission. But that area again, you need a little bit more research. And also we know the role of inflammation and cancer now very well, right? So those cases with the submucous fibrosis having more inflammatory features may have a high chance of transmission, but we don't have data. And also when you see in a OSF biopsy, in this very hyalinized background with very thick fibrosis, if you see new tiny blood vessels coming up, and we call neoangiogenesis in the context of carcinogenesis, when you see neoangiogenesis, I think that is again something that we need to think this patient may be trying to transform. Of course, there are other molecules, various oncogenes or subgenes people have proposed, but I don't know still the validity of those molecules. But something that we need to know, now we apply the dysplasia grading criteria similar to other OPMDs in the oral cavity submucous fibrosis. That may not be correct. We may not be giving the correct grade and we may not be considering the significance of dysplasia in OSF. We all are familiar when we look under microscope, any OSF biopsy, to have a very thin atrophic epithelium, right? That atrophic epithelium, if you see even small slight budding, 2-3 cells, that is how it starts. When it comes, that is the alarm bell, right? So, but in the context of conventional dysplasia, the expansion of the basilar compartment, we don't consider as very significant. But in oral submucous fibrosis, my advice, if you see very slight basal cell proliferation, very tiny epithelial buds, I think that is the starting point of dysplasia, so you need to consider that as significant. So does it warrant different criteria to grade? That is for the future. I think that is again another area where our young researchers should embark on, to look at dysplasia, similar dysplasia grade in different OPMDs together with similar dysplasia grade in OSF, and do follow-up studies and see the outcomes, right? So that, of course, there are a lot of confounding factors. I have no time to talk about those things. But that kind of study should be there if we are to convince others, look, OSF needs another dysplasia grading criteria. As you all know, already dysplasia grading is a little complicated thing. We have made it even a little more complicated. I feel embarrassed for that actually, being part of it. With 16 features, now we have made it 28. I think that's a little complicated, so we need to take some of them down. But we can't take some of them down because we added all those with the literature, available literature. But now we are doing a lot of significant number of studies to identify the biological significance of those features. Now some of those features are probably there just by standards. They may not contribute anything to transformation. So my feeling is one day we should have very little features and perhaps not the 3-tier but the binary grading. It's very easy for even to adapt to submucous fibrosis. I think I will stop there. I'm more than happy to answer any questions if you have.
Any question from the panelists, sir?
Thanks, Tilak. It's nice to hear you talk always. Thank you very much. And I think you pretty much covered everything. And just to add on to what you said, the oral surgeons from Tata Memorial Hospital also have the same experience, that submucous fibrosis or cancer in submucous fibrosis has got a better prognosis. And I think that's what Dr. Pratibha said. And so, thank you. Thank you again.
To sum it up, we have the last part, Dr. Karishma Desai, who will be talking on the various future implications, touching on, I think, most of the part which the other panelists have covered, maybe just giving an insight on what could be the various scope of research, especially in the treatment aspect of it, and what role we could play in that. So, over to Karishma.
Thank you so much, ma'am. And I would like to start first by saying thank you, Dr. Ramni and Dr. Ramya, for organizing and inviting me here. And everybody has, like the panelists, have already summed up most of the content. So I'll just try to move forward and highlight what Professor Tilak said. Let's see what are the potential areas where we could find translational research and we could get to therapy. Now, I haven't synced up with Dr. Rangadi, but we are using similar slides because she is my mentor, so you will find some overlap between our information. So, in terms of pathogenesis, we know that the key mediators are ericholine and TGF-beta. And common management approaches have been laid down, but these are mostly targeting symptomatic relief. And surgery, on the other hand, is invasive, and it does lead to a lot of delay in the healing process. So what should we focus on? I try to broadly categorize the research avenues into one, which is involving the cellular differentiation and cytoskeletal changes. The TGF-beta, which like Dr. Angri mentioned, is the key mediator, and so focus on that and senescence aspect. EMT, with special insights on spatial transcriptomics and metabolomics, newer approaches including stem cells, and development of newer animal models to understand the pathogenesis of fibrosis. Now, coming to cellular differentiation, we already know that myofibroblasts have different origins, right? And they can present with ASMA positive phenotype. Besides this, their frequency definitely increases, and they have certain immune privilege which gives them ability to survive, and they don't undergo apoptosis like it would be in case of wound healing, and hence OSMF is an aberrant wound healing. Now, at KLE and in association with University at Buffalo and National Institute of Virology, I tried to assess how this survival is mediated. So we developed different study groups for treating the fibroblast cells. And overall, we understand that TGF-beta is the key molecule which is running through all of these processes. First, at the very early time point, it starts by reprogramming the mitochondria. Once this sets in, the energy dynamics of the cells change, and post this, the cytoskeletal readaptations take place. Now, this is very important because this is the key idea which is going to enable the cells to survive better. But does survival mean that it's senescent? We tried to look into the TGF-beta pathways to understand this, but we are still at crossroads at understanding senescence. Now, to briefly introduce senescence, senescence is a form of irreversible cell cycle arrest, and this is accompanied by a senescence-associated secretory phenotype. A key factor amongst this one is TGF-beta and MMP. So along with these, the senescent cells predominantly express higher levels of P16 and P21. A Chinese group of researchers recently put forth a study which shows that epithelium of OSMF is the one that undergoes premature senescence. Now, post this senescence, an autocrine or paracrine feedback loop starts in, and this causes a lot of genetic instability, a lot of change in the epithelial and mesenchymal stroma, and it promotes fibrosis and possibly malignant transformation. So, to highlight a few points of their study, they observed that the P16 levels were definitely higher, and these are results of immunostaining. They haven't done transcriptional analysis here, it's just immunostaining data. So, they find that it's higher expression of P16 and P21, and this was positively associated with ASMA expression, as we also saw in the earlier cases and in Dr. Angri's study. Thereafter, they saw that the proliferation markers had gone down, and the Sudan red black, which is indicative of lipofuscin, which is the senescence indicator, goes up in the epithelium of submucous fibrosis. Now, post that, they also conducted some studies on the HOK cell lines using ericholine and different concentrations. The catch here is the concentration is too high at this point in time, but probably simulates what happens in the oral cavity. And they found that the HB gal staining, which is an indicator of senescence again, is increased, and the surface area of the cells is also goes up. So basically senescent cells have a flattened, broader appearance, and they can show a presence of DNA damage, which is through H2AX, which is a prominent marker that's being used. Now, interestingly, guidelines have been proposed to understand senescence. So there are minimal guidelines that you must satisfy to call a cell senescent. We still lack studies which are actually showing these in submucous fibrosis. So this is a very open-ended area for anybody who wants to dive into submucous fibrosis research on senescence. Next, they also studied that TGF-beta level goes up as you would intuitively think of it, and they did ELISA and some other transcriptional analysis which support their findings. Now, coming to EMT, that summarizes my myofibroblast and senescence aspect. Coming to EMT, Professor Raghu's team has recently published a transcriptional study, and they have highlighted that 3 novel candidates exist in cases of OSMF and OSMF turning to carcinoma, which are predominantly SPARC, TGF-beta as you would expect it, and MMP9. Now, this study also answers a pertinent question whether there is a shift of EMT2 to EMT3, that is from fibrosis to malignancy. And this question I remember asking Professor Raghu at our panel discussion at KLE, so they have rightfully put this forward to explain the same. And transcriptomics is basically where, this particular approach is basically where you join bioinformatics, RNA level information of transcripts, and translational approaches to identify and then go for therapy. So now when we know TGF-beta, MMP9 and SPARC are candidates, development of therapies towards this direction is what would help us to prevent the ECM changes and carcinomatous development. Second thing is spatial transcriptomic and metabolomic research. Now this is interesting because this is a leading edge technique that's being found. Here what happens is that they will take the tissue, fixed frozen tissue, and then you would go about analyzing the specific area. So you get spatial information about this particular cell that you are interested in. Say if you're interested in fibroblasts, if you're interested in immune cells, you can get specific information about the same. The key 3 points that I could gather from this research is that they showed existence of in situ carcinoma, partial EMT, CAF phenotype. Now what does this mean? This means that during the transition from oral submucous fibrosis to carcinoma, at some point in time, the fibroblast will develop a partial EMT phenotype. This is like a plasticity that the cell exhibits, and it starts depositing collagen. When we come to the other aspects that they studied that there exists CAF1 and CAF2. Now CAF1 is full EMT, and this is predominantly seen at the leading edge of OSC with carcinomas. And CAF2 are the ones which are recruited myofibroblast-like cells, and these are basically in the OSF regions, and they sort of exhibit immune response. So these 3 are the most important findings that they put forth. Now, just to highlight another thing, what you see here is how you can actually see the trajectory of how the cells are differentiating. You can see the expression level of different genes, and you can actually group together the populations that you find. So a lot of new research has been directed in this direction where they use spatial transcriptomics and metabolomics research. And like in this study, they found metabolomic reprogramming, wherein the polyamine, that is the arginines, spermidine, all of these were elevated, and they promoted tumorigenesis and immune evasion. Another recent study that has been put forth in the Jove journal, that is Journal of Visual Experiments, is where they tried to isolate the cells. So if you can see here, they are actually trying to capture by laser microdetection those particular cells, and then trying to analyze the DNA part of it or the genomic part of it. And what the advantages that this technique has is that it removes the heterogeneity that the bulk OSF tissue brings together during RNA sequencing. So these are some of the developing technologies that you could look at, and like Professor Tilak mentioned, having collaborations with other countries helps you in sort of taking this ahead. So just reinforcing that aspect. And Next is, in this particular presentation, I've just included papers of the last 3 years, so last 3 to 4 years. And when you see newer approaches, you cannot leave stem cells. Now, like Professor Ranganathan said, stem cells have a very gray area. So they can either help you with the disease or they can worsen it, depending on what stage you employ them. The government of India is also propagating the use of stem cell research, but not stem cells by itself. So then we came up with something which is use the secretome part of it, what the cells secrete. So you're not employing the cells, you are actually employing something which is derived from the cells. This sort of bypasses the limitation of using stem cells, right? If you bypassed it, you're going to use the secretome, which has various factors, chemokines, growth factors, pro-angiogenic factors. And we know that there's a lot of immune upregulation going on in submucous fibrosis. So you could modulate that. You could use it to promote endothelial activities. You could use this to stop or promote differentiation of progenitor cells and angiogenesis. And in submucous fibrosis, we are all aware that angiogenesis is something that definitely goes down, and some of the striking papers that I've come across are these. Of course, these are all Chinese research papers, but I'm very proudly, Dr. Kheir's lab is doing a lot of work on secretome. They are actively harnessing the secretome to understand the effect on myofibroblasts and to inhibit the same. So basically, adipose tissue has largely helped in gathering exosomes, which help in breaking the TGF-beta pathways. They have also used vesicles, extracellular vesicles. So all of these are able to, in some way, bypass TGF-beta pathways. Now this is counterintuitive, right? Because TGF-beta is also present in our oral cavity, in our existing microenvironment. So how are these cells doing this? So we are still just there in vivo or just there in the plates. We have not really seen human applications work as effectively. So this is an open area for research, and another part, like Dr. Angadi said and like Dr. Kheir's work will show you, dental pulp stem cells help a lot in bringing down the transdifferentiation of myofibroblasts. They also regulate the epithelial T-cell interactions in fibrosis. Coming to the other aspects that I think one of the senior panelists already mentioned, there are drugs which I think Dr. Tilak actually mentioned it, Professor Tilak. So he said that myofibroblast differentiation is something we should be looking at, right? How do you do this? Like, how do you go about it? So senolytics are one way, but let me tell you, all of these have their applications at this stage in lung fibrosis. They have not been adapted as efficiently in oral fibrosis because of the complexity of our condition by itself. So in terms of senolytics, dasatinib and quercetin have been tried in a lot of animal experiments in cell lines and in idiopathic lung fibrosis. So it basically does, what it basically does is it restores the ability of apoptosis. So the survival of the cells is what has been bypassed here. They will actually lead the cells to cell death. The other group of drugs that you would look at are myofibroblast dedifferentiators. What is dedifferentiation? Now, first we know that fibroblasts turn into myofibroblasts. So they adapt a certain type of metabolism. They adapt to a certain type of cytoskeletal presentation. What does dedifferentiation do? So like myod and these other components, they actually act on these cytoskeletal or energy pathways, and they would lead to deactivation of certain components that cause, again, apoptosis, the susceptibility of these cells. The next thing is photobiomodulation. Now, as easy as it seems, just strike red light on the tissue. It's not as simple. It has very high targeting capacity, very low toxicity, but it's very difficult to sort of modulate, sort of direct. And the dosage and other criteria are very tricky here. So you'd see a lot of work by Dr. Arani's group in this region, but the latest that I found about submucous fibrosis is by Dr. D. Sukanya et al., where they actually reported that PBM helps in increasing the mouth opening by 40%, and this is over a range of 6 months. So these are some of the potential areas that we could be looking at. Now, the last part which I would sum up is animal models. Now, animal models don't really reflect how we would have the disease, but these are great models to learn more about the pathogenesis and then come to the therapeutic application. So starting from 2007, and the earliest was actually Dr. Sirsat, who used mice models or rat models and painted ericoline. I think Dr. Hazare and I studied through the thesis for the same. But in any way, so these are the different categories of animals that have been used, which include the Baltzy mice, the Sprolly Dolly rats, the Spiz albino mice. And again, this work is from Dr. Kher's lab, where they found that as simple as a droplet or a micropipette can be used to create submucous fibrosis in the mice buccal mucosa. However, limitations with mice or rats are that they are very difficult to assess their buccal cavity. So hamsters are what are next being chosen for understanding the pathogenesis. So just to briefly summarize it, I'd say that there are 10,000 ways in which one could fail. And I don't know if you know this gentleman, he is Professor Edison, and he is the one who said there could be 10,000 ways to fail, but if there's one way to do it better, we must find it. And submucous fibrosis is such condition where no amount of research, whether it be biomarkers, whether it be transcriptomics, all are valuable and we must contribute towards this cause. So I hope I was able to put together the approaches that are ongoing and what could possibly lead us to a better therapeutic option. Thank you.
Thank you so much, Karishma. I think it had almost summarized everything, and not to wait long, I hand over the mic to Professor Ranganathan for his final observations.
Thank you. I can have the mic. I can speak in this, okay. Thank you. Thank you very much. I needed to stand up for a few minutes. Yeah. If you all seem a little bit lost, join the gang because you have heard 75 years of work in the morning session, right from 1950s when it was first described. So if it's a little bit lost, it's fine. And this is the most difficult job to do for two reasons. There's a lot of data I need to summarize. Two, I stand between you and lunch. So both are difficult jobs. Trust me, I'm going to keep it as simple as possible because I'm processing a lot of new information. Let me first thank Saveetha Dental College and your team, Dr. Pratibha, Dr. Ramya, for having invited me here. It's always a pleasure to be here because there's a lot of science being discussed. That's always nice. The only disadvantage is too much of concentrated science, which is good. Thank you very much. My panelists, Professor Hazare, Professor Jayanta, Professor Punya, Professor Tilak, Professor Desai, Professor Raghu, and did I leave anybody? Desai, yeah. Professor Dapchari, I think he's yet to join us. Okay, thank you. Oh, he's there. I'm fine. Okay, let me just, I like to approach things from a clinical aspect. And just have this paper, please, a lot of things. Thank you. Yeah, let me quick survey. How many of you are undergraduates? How many of you are postgraduates? Okay. Undergraduates, hands up, quickly. Fast. You have put your hands up, go out. How many of you are postgraduates? Fantastic. I'm sure you're all oral pathology. Any other specialty? Surgeons, anybody? No. Okay, for the sake of undergraduates, what causes OSF? Please do not say chilies, don't say spicy food. I keep hearing that answers even today. I think this is one time when I should tell what you should not say. It is areca nut, period. It's only areca nut in its various forms. That's very important. I think the next question, which is very important, is if areca nut is as bad as tobacco, why is something not being done about it? That's very important. I think Professor Jayanta said it very nicely. It's easily available. It is very acceptable so that even 4 years and 6-year-old people can take it without any stigmata of tobacco attached to it. And second, it is deeply embedded in our customs and rituals. You go to marriages, they give you pan. You go to Professor Hazare's house, he'll give you pan. You know, so it's there everywhere. But the important thing to realize is how you use it. I remember when growing up, we were specifically told that when you're growing up, you can't take betel leaf and areca nut. You need to be married before you can take it. Because one of the effects is it's supposed to be an aphrodisiac. So that's one of the effects. But they would give it to us on the day of Diwali. And you should take it early in the morning on an empty stomach because it's supposed to be anti-helminthic for all the sweets, probably, you know, gives you a good gastric protective effect and improves digestion. Which comes to the next question. I think Professor Pratibha asked that. If it is so good, why is it so harmful? That's true for all addictive substances. Tobacco increases your concentration, makes you feel good. Cocaine increases your concentration. I know scientists who recommend LSD so that they can get new ideas. Please don't do that. But this is all there in the literature, you can Google it. So all these substances start by attracting you, and I think he made a good point of how it smells nice and tastes nice. So they have good properties. And in the case of areca, it increases your cognition, makes you more sharper, makes you more happy. And that's how it starts. And once you get hooked onto it, these effects come down. The euphoria comes down. You develop a tolerance to it. And then the harmful effects take over. Which comes to the next question, what is the harmful effect? Submucous fibrosis. So from the clinical aspect, what do you need to know? What exactly I was talking about this? Why is it so harmful? The first thing you need to remember is it causes your supple buccal mucosa to become very stiff. I do not know if the surgeons ask you this question, but when we were there in college, one of the standard questions used to be, after extraction or oral wound, why don't you get scar tissue in the oral mucosa? That used to be a standard question actually, because the phenotype of fibroblasts are different. Areca just reverses this on its head. And the supple oral mucosa, which is so soft and supple, becomes very, very hard and very, very stiff. And that's because of all the cells in the connective tissue are affected. The fibroblasts, which become myofibroblasts, the endothelial cells, the connective tissue, which is the collagen fibers, the ground substances, and the inflammatory cells. All of them are affected by areca nut. And what is the substance which does that? The so-called alkaloids, flavonoids, and tannins. And adding substances to it like slaked lime, because it's alkaline. Why is it called alkaloid? Because it functions in an alkaline atmosphere. So adding an alkaline substance like slaked lime, though it was used to prevent fungus formation, enhances its activity and creates all these changes in the connective tissue. Once the connective tissue becomes fibrosed, what happens? It starts exerting its effect on epithelium. There is a communication between the epithelium and the connective tissue. The epithelium becomes very atrophic. And atrophic epithelium can become malignant very fast, and that's a separate symposium on its own. And a lot of changes happen in the epithelium. So, though the fibrosis happens in the connective tissue, the malignancy happens in the epithelium. You get a squamous cell carcinoma, you don't get a fibrosarcoma. The fibroblasts don't become malignant. So there is a crosstalk, and I think you must have heard about being repeatedly epithelial mesenchymal transition. Can we de-differentiate the myofibroblasts back to fibroblasts because you're causing a lot of harm? So there is a lot of interaction between epithelium and connective tissue. So both the connective tissue is harmed and the epithelium is harmed. The patient lands up in your clinic because he or she cannot open the mouth, cannot speak, cannot swallow. And the patient lands up on the surgeon's desk because this fibrosis eventually leads to squamous cell carcinoma. Fortunately, it's not very aggressive, but that's not an excuse to get squamous cell carcinoma. And the other question which was asked is, areca nut alone, how harmful is it? If you combine it with alcohol and smoking, how harmful is it? Yes, it is synergistic and sometimes the effects are cumulative. When you combine all the three, the effects are even more. The next question your patients would ask you is, I know my friend chews 10 packets of so-called pan masala a day, nothing happens to him or her. I just did 1 packet of areca nut and I developed early features of submucous fibrosis. This is once again the same thing which happens in any part of medicine. We shouldn't be surprised. I mean, if you have brothers and sisters, same parents, same food, same environment, One goes to 6 feet tall, the other one is only 5'6", 5'7". And this is what we meant when we said that genetic polymorphisms exist. You may have the same genes, but each of these genes are of different types. And the most important polymorphism, the two most important polymorphism is one, which decides your susceptibility to disease, HLA, I think D3 and D7. And this is true for so many diseases. If you have rheumatoid arthritis, they will ask you to do a HLA testing. If you have Sjogren's syndrome, they will ask you to do a HLA testing. So whether you're susceptible to or not. The second thing polymorphism does is how you can metabolize drugs. The classic example is 6 of you or 7 of you go to have a dinner or have a party. You eat the same stuff, same restaurant. 3 of you develop a bad tummy the next day. The others don't have anything at all. They're doing gloriously well. That depends on how you metabolize what you've taken. And that is what we talk about when we say cytochrome P450 and the related genes. And I think Professor Raghu made a mention of xenobiotics and endobiotics. How you digest, how you metabolize different substances. That is very important. So there are genes which control every aspect of submucous fibrosis. One of them is susceptibility. The other one is progression of submucous fibrosis. And the key agent is TGF-beta and the so-called SMAD pathway. 2 pathways. There's one pathway called classical or canonical and non-classical or non-canonical pathway. So the TGF-beta and SMAD are the key players in submucous fibrosis. The co-players in this are those which cause hypoxia and reactive oxygen species. And I think it's a very fancy thing for any disease to give antioxidants. Just give antioxidants, any disease, cardiac problem, antioxidants, diabetic problem, antioxidants. But a word of caution from the clinical aspect. Antioxidants prevent reactive oxygen species. Why do you need to prevent them? Does anybody know? Why are ROS or reactive oxygen species harmful? Sorry? They cause damage to the DNA, right? But there is a fine point to this. What is the maximum DNA you have in your body, do you know? Which cell or which tissue has the maximum amount of DNA? I think a brief mention was made of that. You have more micro DNA in your body than human gene actually. The genome of microbes, the bacteria. So that's a big science today. Anywhere you go, you have one Dr. Paul talking about gut, everybody talking about gut microbiome. See, everybody nodding. See, power of YouTube more than textbooks actually. Yeah, so microbiome is a very powerful thing. The body uses ROS to destroy microorganisms and cancer cells also. So it's a tough one. People come and tell, I routinely prescribe antioxidants. It's a dangerous thing to do. There are numerous studies which actually show that antioxidants can worsen certain types of tumors and cancer. This is very old study of vitamin C and lung cancer, which was stopped halfway through because it had a harmful effect on lung cancer. So yes, antioxidants are very useful because ROS or reactive oxygen species is one of the mechanisms by which OSF is initiated. But that doesn't mean you can use it randomly. Which segues me to the management part. So how do you manage this? Why is there a problem in managing submucous fibrosis? One, the fibrosis is irreversible. We briefly mentioned about that. 2, the cells which produce the fibroblasts, the connective tissue or the collagen fibers are also altered into myofibroblasts. So even if you take away the scar tissue like in other parts of the body, you do not have good fibroblasts to produce good collagen. It's still abnormal collagen. So even if you stop the habit, even if you have a surgical procedure, the scar tissue persists and is very difficult to treat. And as long as the scar tissue is there, you have hypoxia and you have alterations of the epithelium which eventually becomes cancer. And Professor Tilak made a very important point. And he said that if you start seeing new blood vessels forming within the connective tissue, which is one of the ways to tackle submucous fibrosis by using related substances, that could actually be a sign of early cancerous transformation within the epithelium. Neoangiogenesis, we know, is one of the early hallmarks of cancer starting and spreading. So, to sum up all these, areca nut is bad. It causes submucous fibrosis, which affects both the connective tissue, which causes a lot of morbidity. The associated squamous cell carcinoma causes mortality. So this is where the problem. As far as treatment is concerned, we have been talking till the cows come home. Why don't we have treatment? We have approaches. We have a lot of approaches where we can tackle any of these pathways. We could tackle the metabolism of areca nut. We could tackle the TGF-beta pathway. We can tackle the reactive oxygen species.
Or we can use newer technology like stem cells to produce good fibroblasts so that you get good collagen and the mucosa becomes supple again. Leaving aside all that, what is the best treatment? Prevention and informing the public about how harmful areca nut is. And I think Professor Jayanta made a mention that policymakers must be made aware of this. And I think Tamil Nadu was one of the states which initially implemented this ban from 100 feet from all schools. Areca products should not be sold. And let me just finish this with one small anecdote. Normally, we give wedding invitations, we give the card and we give some betel leaf areca nut. So one of my postgraduates just got married recently, and when she gave me she had betel leaf and one rose flower. I said, where's the areca nut? She said, no, sir, you have said areca nut is harmful. I said, my job is done. If I've convinced you, then I should convince the policymakers next. Thank you for your undivided attention. Thank you very much.
Thank you so much, sir, for that crisp but very powerful remarks or the key points you have noted from the symposium. Any questions from the floor? And I hand over to Professor Hazare, and then the final concluding marks will be given by our evergreen Dr. Daftari, who's been patiently waiting online, I think, for close to 2 hours at this age. Really, really great, sir. We are really, we can see the enthusiasm at this age, and I think you're a source of inspiration for all of us as I think it's something remarkable which the entire generation should follow. Any questions?
Is there any role of PRP in autologous PRP?
We just reviewed a project yesterday, actually. It's probably by its action on the vascularity and creating new cells. That's the only role of PRP. A lot of people are working on that, and I think you made the point, or Professor Desai made the point, that there's a lot of curbs on using stem cells. And once again, the term stem cells is used very loosely by many people. That's another topic by itself. But if you have PRP or PRF, that sort of bypasses using stem cells from the blood. Basically, it's not exactly the same, but similar to using a secretosome. It's supposed to create some reduce the inflammasomes and create new cytokines and good inflammation. That's probably, including plasminogen. I think you made a mention of plasminogen. Yeah.
So, good afternoon, sir. I don't have any questions. It is an amazing team of senior people till junior Karishma Desai. And thanks to Pratibha Madam for organizing such a lovely love and care, stomach and academic knowledge when I come to Saveetha College. See, I can't categorize myself as a senior oral pathologist. I can't even call me as a junior oral pathologist. I am somewhere in between two categories. Modern era. So you're trying, so 7th generation, maybe I may be 5th or 6th generation. I just want to give few add-up points for the team. I am holding two positions as a pathologist, as a clinician. So I have few things in my mind, but I never get these kind of opportunities. If I miss these opportunities to put this in table, I don't get any opportunities in my life. Two things. We, as a population of India, we have been shifted to migrated to other countries as our laborers to cultivate plantation, sugarcane and betel nut. And we have our own cultural habits of having betel nut chewing. So this SMF came somewhere around 80 years or 70 years, 75 years. Before that, we don't have much history or data of SMF. Okay, SMF. And the thing is, in that 70, 80 years, recently the SMF has become more in limelight from past 20, 25 years. The thing is, we have a complete knowledge for oral pathologist and general dentist. So my doubt will, my point will be, the thing is, we can't ask government or we can't ask policy makers every time because nothing had happened till now. Okay. So what I feel means, and we can't legally, or I can't say anybody to stop or reduce. Probably I can advise them to reduce, I can tell them to reduce or minimize. The thing is, what I feel, our juniors, the language of pathology has been converted to language of clinicals. The early signs of malignancy has been conveyed to them. I think the data will be, we have much more data of OSMF because all the OSMF, I see in my clinic, all somewhere around the terminal stage only. The awareness should go with images of initial stages of OSMF to students. The eyes, what I see in clinic, no, so I have to catch. Now my eyes are trained for squamous cell carcinoma with a small 2 millimeter ulcer. So as a pathologist, if we see 2 millimeter ulcer, previously in cigar packets, we see big images. Until we get a big images, I think that I don't have cancer. Now the things we have to convey to the undergraduates or convey to the students in a smaller way, the one thing. The other thing in my practice, like what Tilak sir said and what Raghavan sir said, no, I have seen a patient who is under my treatment, almost I follow for 16 years. He had developed 3 squamous cell carcinomas. I have did excision biopsy, it has healed. Then another area I did excision biopsy, it had healed. And third area, it has developed excision biopsy, it had healed. I'm not saying that oral squamous cell carcinoma is curable. I can say it's curable as an initial stage, but that fellow, what he is thinking that Arvind can treat all oral squamous cell carcinoma. Whenever you go, you will do biopsy and it will get cured. That's one point. And I see more amount of cases, OSMF turning into malignancy, because of chewing habit, no, all teeth will get untreated. Because of lack of inability to open the mouth, no, there is so much of traumatic ulcer causing in tongue and buccal mucosa. Out of me, 10 cases, 7 cases in OSMF, it's to be a traumatic ulcer in buccal mucosa or traumatic ulcer in the lateral part of the tongue. So these things can be considered and it can be put into a shell and it can be passed to the next generation of pathologists. So pathology language, I feel it has to be converted into or translated into clinical language. We have listened everything, but I couldn't able to convey this to my fellow oral medicine doctor or fellow oral surgeon. They don't even know what TNF or what VG or everything. We have sufficient knowledge, but this is high time we have to translate pathology language into a clinical language, and by that way we can reduce the prevalence of OSMF. Thank you, sir.
If I can add.
Yeah.
Now, historically, we Bengalis have been writing everything down for last 400 years. And that is roughly around from the time of Jahangir. Now, in our literature, we have mention of typhoid, malaria, even oral squamous cell carcinoma. That means Ramakrishna Dev died of oral squamous cell carcinoma, CA. But surprisingly, we have never heard anything such a dramatic disease. I have never read anything in our literature or history of submucous fibrosis. This is one thing, sir. And the second thing, in my clinics, we do a lot of clinics in Ahmed, our hospital. We get 2 forms of patient. Now this chewing of areca nut in itself is becoming unpopular. It is popular with the older individual. In these people who are 75, 80 years old, I get a mucosa that is firm, even leathery, but they don't have trismus or the burning sensation is not there. In another group who is around 25 to 35 or maybe 40, they don't have a mucosa that is that leathery, but they have almost complete trismus. So are we dealing with 2 diseases or 2 forms of the same disease?
Yes, I think you had already talked about regional variations, and we'll take up, when we sum up all these recommendations, including Dr. Arvind Kumar's, let's listen to Dr. Daftari. Sir, are you there? Are you there?
Am I audible?
Yeah, but please take 5 minutes because I need to, conclude with the recommendations. So please, over to you, Dr. Daftari, for 5 minutes.
Well, I will take less than 5 minutes, of course. Am I audible?
Yes, sir, you are visible and audible.
Yeah. I am new to technology and new to subclinical fibrosis research also, of course. I thought we were linked by SMF so much at this moment. Hello. I thought we were linked by SMF, but now today, hearing all these presentations by the people, the new concepts, new hypotheses, one realizing the time has come when all of you are going to demystify subclinical fibrosis. And once the demystification starts, and if the presence is as strong as you are showing it to me today, I am sure the present will become a future and we shall be in a happy state where subclinical fibrosis will be effectively demystified with the oral pathologists. Oral pathology have used the clinical arm to brought subclinical fibrosis into reality, and you will be the ones who will bring back the subclinical fibrosis in a true concept without any mystery attached to it. So I congratulate all of you, all the speakers, all the concepts, all the hypotheses, all the science that has been given this particular morning. It's been a collective effort in a big way, and I'm looking at the final answers coming in a shorter period of time. There are few things that always happen. As of now, of course, I'm still an HRE dad. But today, listening to you, I'm sure that I have also imbibed a certain amount of basic pathology in a big way. There was a question about molecular transformation, and I can only mention that our follow-up studies have shown the largest molecular transformation is seen in nodular leukoplakia, which is about 3,343. The next one was SMF, which was 393, relative risk. So from that angle, SMF is still a force to be reckoned with, which was an unknown entity way back when we started the research, became a force to reckon with by 2004 and so. So one cannot ignore, of course, the oral subclinical fibrosis at all. You people, all of your studies have done the oral mucosa study where different hypotheses are brought forward of being affected by the fibrosis. The one would like to wonder how far the esophageal mucosa has been or will be affected by the same habits. Because in Maharashtra, we have a higher number of esophageal cancers, and the only habit the only habit which is a positive habit is that chewing of the areca nut. And we all know in Maharashtra, when you chew areca nut, you swallow the areca nut. While in places like Kerala, when you chew areca nut with tobacco, you spit it out. So there was only one question, that whether you have any information at a later stage, how far the esophageal mucosa would be affected, if at all, by areca nut. During those days, I had taken a little trouble doing the esophageal biopsy because they were willing to do it for us, and I found not much of a change happening in a subclinical fibrosis patient in esophageal mucosa. That's just a preliminary few biopsies that I had taken and studied. So with these few little observations, I wish you all the best. I'm very happy that what's happening at that level of science is very progressive, and I'm sure you who will bring that present research into final fruitfulness for all of us. Thank you for allowing me to say a few words, and I'm happy to be around at this moment. Wishing you all well, and thanks a lot. Have a pleasant morning and lunch. Thank you.
Thank you, sir. You have just listened to
Thank you, Rahul. Thank you, everybody.
So, in fact, we have listened to 88 years young man, Dr. D.K. Daftari, still mentoring all of us, and he has expressed definitely a new ray of hope.
I'm sure, of course, and I suppose I've taken less than 5 minutes, Dr. Azari.
Yes.
Thank you for asking me to say.
Thank you for that. That was the most difficult job for me to do. Anyway, because your blessings are always required, and so long as OSMF is not resolved from this country, we will continue to work. I believe, like Indian childhood cirrhosis was once upon a common disease in Indian scenario, and I have a dream that oral submucous fibrosis will have a similar fate like Indian childhood cirrhosis. And that's what we need to work, all 21st century people, including, I think I am the senior most. Yes, Ramesh, in that, our group. So really, it has been a wonderful meeting, and Pratibha, I don't know, how you have got that concept of fostering a standardized protocol for OSMF, clinical and pathological consciences, to it the intervention also, and research, of course. All these presentations will take it up. I just wanted a small recommendation note to go, which we will modify along with the panelists led by our, Dr. Ranga, and he can take it really on the international platform. So on behalf of all of us, I would like to just, that was my first slide, so it has come on record, gratitude towards the entity, Dr. N.M. Virayan Sir, Chancellor, Dr. Deepak Dallaswamy, Pro-Chancellor, Dr. S. Suresh Kumar, Vice-Chancellor, Dr. Ashwini Kumar, Pro-Vice-Chancellor, Dr. Sheila Varghese, Registrar Madam, Dr. Arvind Kumar, Dean, Dr. Pratibha, our colleague, and the team, staff, students and management of the Saveetha Dental College, and it's with the gratitude. I think we have some international conference on craniofacial pathology and biology. It's a good confluence. And this, I take opportunity to just frame some points which can be modified. These are the recommendations. Erica nut is a class 1 carcinogen. There was still a debate going on. In Kodaikanal conference, before that, there was some paper news, and we have strongly objected that definitely we are, it's a Erica nut is a class 1 carcinogen, which is the etiological factor, main etiological factor for OSMF. So far, there is no permanent cure for OSF, and further studies are needed to identify the targeted therapy for the disease, like personalized medicine and stem cell concept. So research will come. There is a need of Center for Excellence of OPMDs as a consortium consisting of national and international advisors. Pratibha, you can take up with your management, and we all are ready, including Professor Samanvar Nakula Surya, Professor Tilak Ratne, and we have from University of Malaya, our own alumni, Dr. Anand. We are all ready. And advocacy with proper authorities, everybody feels the needs of, that advocacy for strict implementation and legislations. There is a COTPA, and now this Erica nut cessation has to be actively implemented. Erica nut and tobacco research. So these were the few recommendations. We will definitely, nurture upon it, and will submit to the proper authorities. And believe me, all of us. And this is a photograph I have borrowed from Professor Akhtar, orthodontist from Yenopea. He is such a beautiful photographer, and I just wanted him to, give this. You can see his color bottles also, same, years in years. So really the true glamour lies in oral pathology and oral pathology. Okay, thank you. With this, I thank all my colleagues, Professor Ranganathan, Dr. Jaya, and all of us are really benefited by lively interaction, and Thanks to Pratibha and her team, I think these are the concluding remarks from our panel with these recommendations. And thank you so much.
Thank you all. Thank you, panelists, for the wonderful, I think it was, as Sir said, concentrated session. And I think we look forward to seniors guiding us who are like Professor Hazare, Professor Ranganathan Sir, to take this up along with Prof. Tilak and Raghu, to take this up because and do something about it. We are ready to, as far as this consortium or this consensus meeting was concerned, was because we wanted to have people who are working on it, who are still pursuing the path to eradicate this sort of deadly disease. And as we are getting to see more and more of OSCC, so it's our humble request. We look forward as senior faculty to take this to the authorities across in India and international fraternity to make awareness of this particular condition and like at the end of the day help the people around. Thank you so much. And it's time to honor our esteemed panelists. We request Dr. Ramesh and Dr. Shivapal Sundaram sir to kindly help us with the same, as they are again a part and parcel of this team and been working. And we also look, sir, Dr. SPS sir, to join this team and help in formation of the consensus and be a part of the team, sir. Thank you so much, sir. Professor Ranganathan sir.
We want all the online participants also to pose with us. Yeah, this is for a joint photograph. Yeah.
So the certificate of appreciation is here, sir. Thank you, sir. Thank you, sir. Thank you, Karishma.
Thank you, Abhilasha. Thank you, Ramya ma'am and Pratibha ma'am.
So now we will break for lunch finally. And you can come back for the oral detect workshop, which is going to be more interesting.
Thank you very much, Dr. Pratibha, Dr. Ramya.
Thank you, sir. Thank you so much, sir. So next time we hope
Dr.
to
Ramya,
have you
I
in
need my
person.
shawl too.
Sir, your shawl is also here, sir.
Yes.
So next time you can come in person, sir.
No. The shawl has to come and meet me.
It's coming, it's flying towards you.
Thank you, thank you.
Thank
sir.
you very much, Karishma. Thank you, Dr. Tilak, and everybody. It was wonderful as always.
Yes, and I loved our
We continue to do good
session
science.
chat.
Thank you. Bye, sir.
check. Test mic 1 2 3 hello test check. Hello. ಅದೇ ಮಾತಾಡ್ತಾ ಇವೆ ಬೇರೆ ಮಾತಾಡ.
Hello, check. Okay. Check.
Hello, test. Test mic 1 2 3 hello testing check. Hello, test 1 2 3 hello test. அந்த அம்மிங் சவுண்ட் வருதா இப்போ? Hello, test 1 2 3 hello testing. My testing 1 2 3 hello testing check. Hello, test 1 2 3 hello test. Hello, test. Test mic 1 2 3 hello testing check. Test. Test mic 1 2 3 hello testing check. Hello, test. Test mic 1 2 3 hello testing check. Hello, test. Check. Check. Hello. Hello, test. Test mic 1 2 3 hello testing check. Hello, test 1 2 3 hello testing check. Hello, test. Hello, test. Check. Check. Hello, test.
ஹலோ ஹலோ ஒரு கேபிள் நல்ல கேபிள் நேற்று முந்தா நேற்று ஃபங்க்ஷன் போட்டு எடுத்து தான் வந்தேன் செக் செக் ஹலோ 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 கேளுங்க உங்களுக்கு தெரியும் சும்மா வைங்க ஹலோ 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 சும்மா அது அது வந்து ஆடியோ கேட்கறதுக்காக தான் இருக்கும் எப்படி இருக்கு பாருங்க ஹலோ கேட்குதுங்களா எதுவுமே இல்லை பாருங்க
நம்ம பேசாம இருங்க அப்படி அந்த
அது வந்து ஓப்பனு பேசும்போது வருதா பாருங்க வராது பேசும்போது வரல ஆமாம் அதான் அப்படி தான் இருக்கணும் இப்போ ஷார்ப்பாக இருக்கா ஆடியோ அந்த ஷார்ப்பு தான் நம்மளுக்கு அங்கே வேணும் மிக்சரில் போட்டால் ஷார்ப்பு வரும் எப்பவுமே மைக்கில்
மிக்சர் நான் இப்போ வந்து
நான் என்ன சொல்கிறேன் இருங்க ஒரே நிமிஷம் அந்த டவுட்டே வேணாம் சின்ன சாங் மட்டும் நான் அந்த மைக்கில் வச்சு பார்க்குறேன் ஒரு வாட்டி கேள்வி
மிக்சரில் வந்து ஸ்டூடியோ மாஸ்டர் இருக்குது அது இதில் கண்ட்ரோல் பண்ணி ப்ராசஸில் நான் கண்ட்ரோல் பண்ணிக்கிறேன் ப்ராசஸில்
அதுதான் அது இன்னைக்கு முடிச்சிடலான்னு பார்த்தேன் திடீர்னு சவிதா டென்டல் காலேஜில் ப்ரோக்ராம் இன்னைக்கு நாளைக்கு முடிச்சுட்டு நாளைக்கு விடிய காலையில் கிளம்புறேன் திருநெல்வேலி போகிறேன் பாளையங்கோட்டையில் ஒரு இது கிரகப்பிரவேசம் அதுக்கு போகிறேன் அதனால் நான் என்ன பண்ணுறேன் அந்த ஒரு 20 ஷீட்டை மட்டும் உங்களுக்கு அனுப்புகிறேன் எல்லாம் செட் பண்ணியிருக்கு கரெக்ஷன் பண்ணிவிட்டு பேக் ட்ராப் போடணும் க்ளோஸ்அப்பில் ஒரு 6-7 தான் இருக்கும் இந்த 20 ஷீட்டில் எங்கே கேப் விட்ருக்கணும் அங்கே ஃபில் பண்ணிக்கிங்க ஃப்ரண்ட்டு சீட்டு லாஸ்ட்டு சீட்டை மட்டும் எப்படி பண்ணணும்னு அவர்கிட்ட கேட்டுக்கங்க நான் மொத்தமாக நான் உங்களுக்கு அனுப்பி விட்றேன் 20 ஷீட்டை மட்டும் நான் அனுப்புகிறேன் ஓகே இல்லைன்னா நான் மொத்தமாக என்ன பண்ணுறேன் நான் பண்ண ஃபைலையே அப்படியே மொத்தமாக உங்களுக்கு அனுப்புகிறேன் நீங்கள் அதுலேருந்தே இது பண்ணிக்கோங்க ஏன்னா சப்போஸ் ஃப்ரண்ட்டு லாஸ்ட்டு கேட்பாரு அது பண்ணி கொடுங்க நான் உங்களுக்கு மொத்தமாக நான்
test mic 1, 2, 3. Hello, test, check, test. Hello, test, check. Hello, test, check. Hello, test. 1, 2, 3. Hello, testing, check. Hello, test.
2:30 PM போட்டாங்க. இது ஷெடியூலு 2:30 PMனு போட்டாங்க. 2:40 ஆயிடுச்சு. மாற்றணுமா? எதுவும் 3 o'clock மாற்றவா இல்லை இப்போ ஆரம்பிச்சிருவாங்களா? கேட்டுட்டு சொல்லுங்கள். ஆ ரொம்ப லோவாக தான் வச்சிருக்கேன். ஆமாம், காது கேட்கல. வருது. இதில் என்னென்னா ஈக்குவலாக வரல. இந்த சைடு கம்மியாக இருக்கு. நான் அது சரி பண்ணேன். வருதா கிளியராக இருக்கான்னு கேட்டேன். இது வருது. பீப்புன்னு ஒரு சவுண்டு வருது. கேட்குது. இது சுத்தமாக இல்லையா? சரி, நான் இப்போ மைக்கில் போட்டுறேன். ஒரு இது சேஃப்க்கு போட்டு வச்சு 2 இதில் எது வருதோ அது பண்ணிக்கலாம். லெவல் வந்தாலே வரும். பத்தலை. அவர் வந்து 2 நாள் திண்டிவனம்
Greetings from Malaysia. Thank you for inviting me to
Good afternoon, everyone. We'll start with the session 2, plenary session 2, the oral detect workshop. Now, I would like to give a brief intro about the speakers of the session. Dr. Anand Ramanathan from University of Malaya, Malaysia. Sir did his Bachelor of Dental Surgery from the Tamil Nadu Dr. MGR Medical University, Chennai in 2002, and then did his Masters in Oral and Maxillofacial Pathology at Raja Mutaya Dental College and Hospitals, Annamalai University in 2009. In 2011, he migrated to Malaysia and obtained his practicing license. He then joined the Faculty of Dentistry at the University of Malaya and has become a valuable lecturer and clinical specialist in the Department of Oral and Maxillofacial Clinical Sciences. He has been the undergraduate discipline coordinator for oral medicine and oral pathology. He is currently a member of the Curriculum Review Board for the undergraduate and postgraduate in oral path and oral medicine at the Faculty of Dentistry, University of Malaya. Sir has numerous papers to his credit, and he is a member of various board, and he is also the member of Oral Cancer Research and Coordinating Center, the Faculty of Dentistry, University of Malaya. Next, I would like to introduce about Dr. Rosna Binti Zain from Masa University, Malaysia, who will be joining us online. She is a consultant in oral pathology and oral medicine, University of Malaya. She received her Bachelor of Dental Science from the University of Queensland, Australia in 1977 and joined the Faculty of Dentistry in University of Malaya, Kuala Lumpur. She began her clinical and research training at the University of Michigan, Ann Arbor, and received her master's in oral path and diagnosis from the University of Michigan and her fellowship from the American Academy of Oral Pathology. She was appointed as a lecturer and assistant professor, and now she is a professor in oral pathology and oral medicine. Ma'am is also involved in various research projects, and currently she has a special interest in standardization of various methodology in clinical and pathological criteria towards achieving credibility in all aspects of oral cancer research. Then I would like to introduce the chairpersons of the session, Dr. Ramesh, former Dean, MGPGI Pondicherry, and Dr. Sivapada Sundaram, Principal, PDC Chennai. I would like to call upon Dr. Anand sir to start with the session.
Thank you, MC, for your kind words. I'm happy to be back to my alma mater here. I did my undergraduation from 97 to 2003 in Saveetha Dental College, and so happy to come back here. So let's start this training and calibration for early detection of oral cancer. Introduction by Prof. Rosna. It's a pre-recorded introduction, so please listen. Thank you.
Greetings from Malaysia. Thank you for inviting me to deliver this lecture on training and calibration for early detection of oral cancer called Oral Detect. Oral Detect was developed by Oral Cancer Research and Coordinating Center at the University of Malaya, where I have been for almost 35 years. I am currently at Masa University while also holding an emeritus professor position at University of Malaya. Oral Detect is a structured training program which consisted of well-planned series of lectures which are diagnostic criteria and differential diagnosis of oral mucosal lesions. These are followed by spot tests, which uses clinical pictures to test on diagnosis of lesions, and discussion session with corrective feedback, where sessions were conducted soon after the spot test. I will be talking more about this in another lecture. Just in brief, we have been doing training for a number of years, and this is some of the outcome of our training. If you notice, at the pre-test, which is a spot test just before the lectures, we have different groups of people taking this program, and their level of knowledge is varies from 55 to 65 to 75%. And this group are the oral medicine and oral pathology and oral surgeon group. The periodontist is group 2 and the restorative specialist, and group 3 the dental officers. And if you notice, after the lecture, the first post-test brings them up to a higher level, and after the post-test 1, where we conduct discussion session with corrective feedback, the level increases to about 85% and above, where our criteria is actually to achieve to at least 75%. And from then on, the post-test reveals that there's not much change, but I will explain this later why these post-tests are being conducted. The following are present in the training package. Firstly, the pre-calibration of spot diagnosis. This is followed by a systematic examination of the mouth and related areas, and then the first training lecture is being given, which is on criteria for diagnosis of red, white, and red-white oral mucosal lesions. Training lecture 2 will be dealing with criteria for diagnosis of oral pigmented lesions, ulcers and swellings, and training lecture 3 will be dealing with differential diagnosis of red, white, and red-white oral mucosal lesions, while training lecture 4 will be dealing with differential diagnosis of oral pigmented lesions, ulcers, and swellings. Then we will conduct the first calibration or the spot diagnosis soon after the lecture sessions. And soon after this spot diagnosis, we will be discussing your answers for the first calibration and spot diagnosis, and this discussion will include the reasons for why you have given the correct answers or why your answers are incorrect. However, these are all done anonymously. Then we proceed to the second calibration or spot diagnosis, and followed by the discussion of answers for the second calibration or spot diagnosis, where again it is on corrective feedback of your answers. Then we followed on with the third calibration or spot diagnosis. And at the end of it, we usually award the certificate of achievement where candidates had achieved more than 75% of accuracy by the third spot diagnosis. This training program is being recognized by the Oral Health Division, Ministry of Health Malaysia, and we do training of trainers where the trainers then eco-train all their dental officers in the Ministry of Health. Originally, when we started doing this, we have a guidebook, and these are present in the training package, and the guidebook is on oral mucosal lesions, and we initially give them a hard book of the pictorial copies, but as time goes on we decided to just give them the digital copy of the pictorial book. But by now we do not give any books because there are many oral mucosal lesions pictorial books that can be referred to and would be equally effective. This training program has been conducted, as I said earlier, at the Ministry of Health Malaysia, and these are done as training of trainers, where the trainers will then go back and eco-train their dental officers throughout the whole of Malaysia. This is specifically a program by the Ministry of Health Malaysia. We have then followed through to do training of students in the University of Malaya, and this training is more of a competency training of oral mucosal lesion detection and recognition. Similarly, this was introduced to final year students in University Kebangsaan Malaysia, another public university in Malaysia, and this was also introduced to final year students in Masa University. I will be speaking about the results and the outcome of these training in the next lecture. Oral Detect training program is also being conducted in the University of Putih Sastra Phnom Penh, Cambodia, to their dentists and later also to their students. And in Cambodia, there was at one time where we actually conduct this for the year 4 and the year 6 dental undergraduate students, and interestingly we were able to get the same results. We also bring this program to Indonesia, where we conducted training of trainers early detection for oral cancer program for the dentists in Indonesia. We also train the dentists in Kathmandu, Nepal. We have also gone to Chennai, India, and did the same thing, but a very shortened version. So with this oral detect program, we could customize it to suit the needs of, or the needs and requirement of the institution. However, when we shorten it, the outcome may not be as good as the outcome if it is the whole program. And lastly, December 6, 2024, I had gone over to Dunedin, University of Otago, where I have conducted a training program for the dentists as they are embarking on a screening for their indigenous group in New Zealand. So with that, I would like to end this session, and I will be back with a lecture on the actual effectiveness of oral detect program. Thank you.
I request Ramesh sir to kindly give his comments.
Afternoon to everyone. You know, I must really congratulate the organizing team for taking up this type of a workshop. I tell you the reason why. See, when I was a student, undergraduate student, the oral cancer was top in the list in the top 5 cancers in the Indian scenario. But even today, it tops the third place. So that means the situation has not improved. For one reason that there's some linkage is missing. Something is wrong. Either we are not able to understand the process or the cause for it, or we are not able to tackle the treatment part of it. This is what can happen. Now, any disease, for that matter, has to be dealt in 3 or 4 steps. First, understand the disease. What happens? How it manifests. Second aspect, you try to pinpoint the cause. What is exactly the reason for which the disease is coming up? Once you pinpoint that, probably the treatment becomes easier. Like, for example, in tuberculosis. We know for certain that tuberculosis bacilli is a culprit. So we have a drug and we are able to do that. Unfortunately, when we deal about the oral cancer, it's a multifaceted disorder. In fact, all the potentially malignant disorders, it's a multifaceted. It cannot be on one single cause. As the previous speakers have pointed out, if you try to cut down the cause, if you know that one cause, we'll be able to cut it short. But previously, smoking was dominating the scenario as a cause. Now, when that has come down, smoking has come down, but chewing habit has increased. So we are not able to control the process. That is how we lose our control on the tackling the cancer cases. Whereas in other countries, somehow they are able to keep a track on the things for only one reason, that they are able to detect the disease at the early stage. So we have no choice. Understanding the process, thousands of papers are coming up. But then, what is the final outcome? We don't have a single common consensus that this is the reason for any specific disease. That is not there. We are not able to do that. So that choice we don't have. The second aspect is, disease, when you do the treatment for a disease, like any disease, catch up at the early stage. Probably the treatment part becomes much more easier. Morbidity is not much, and mortality also we can reduce it. That is where we stand now. So, what is in our hand? For the time being, detect the disease at the much earlier stage. I am very happy that Dr. Anand and the team from Malaysia, the experts, they have come out and they are going out globally, and very happy that at least the early detection will give some form of result for our tackling the disease. So in that aspect, I really appreciate him because he has got a long session to go. I'm told that 3-4 hours. But then it should be effective for people who are in the periphery level, that is the clinical level. When they catch up the disease at the very early stage, probably the success will be much better. That is the aim with which the organizing committee has organized this program, so that to some success, because cause, we are still in the unifying cause is not there. It's a multiple causes, so that is difficult to treat. Once in advanced stage, that is difficult. So the linking process, try to catch up with the early stage. Now in India, unfortunately, most of them, they come at the very late stage. So we are not able to control the disease. So his workshop will certainly help to catch up how the disease looks, how the suspicion arises, what you have to do, and if it is so, you try to cut down the entire pathological aspects. So that way, his talk is going to be very immense useful for the beginners. So kindly pass on this. If it reaches 100 people, probably this will be a benefit for the entire society. So with this, without taking much of time, because he has got a long session to think, and also this is of much socio-economical benefit. So with this few words, I hand over the mic to Professor Anand and the team to go ahead. Thank you.
Thank you, Prof. So, without much ado, I will start my session. We are already a bit late, so I don't want to keep you too long. So this is what we are going to do today. Sorry about the time. The Indian standard time is fine, but the Malaysian standard time is not. So we are already at 3 o'clock. So the next one will be systematic oral mucosal examination. Then we will go with the pre-calibration assessment. I am not sure whether we have given the numbers, participant numbers. So if you have not given the participant numbers, then we will ask them to write their name as such in the Google Forms. We are going to use a Google Forms, so be ready with your mobile phones. So you can fill up the Google Forms there. Then followed by 4 lectures. And we will end today's program with calibration assessment 1. Okay. So this is tomorrow's program. We will see that later. Sorry. Okay, coming to the systematic oral mucosal examination, I'm sure that most of you would be doing ICDAS for dental caries and perio-charting for the periodontal status. Those are very complex chartings, and it usually takes about 15 to 20 minutes per charting as such. But systematic oral examination is just 2 minutes. And that 2 minutes decides whether the patient has a good quality of life or not, because it takes only 1 month for a T1 or T2 to go to T3, T4. We know that the later stages, advanced stages have worse prognosis and the quality of life is bad, whereas the T1, T2, the early stage ones are much better. So just invest 2 minutes in each of your patients it makes a big difference to them as such. And these are the armamentariums. It's not necessary you should have this. You can have one mirror and your fingers should be fine. And a gauze piece. So I'm going to go around the mouth 6 times. So let's start with round 1. So what are you going to look at is you're going to look at whether there's white lesion, red lesion, or mixed red and white lesion, pigmented lesions, ulcers and swellings. So all our pathology inside the mouth can actually come under one of these categories as such. So we are going to look at that. And so you start either from the right corner of the mouth or the left corner of the mouth. So once you start from the right corner of the mouth, go towards your upper lip and go to your left corner of the mouth and then back to the right corner through your lower lip. So that's going to be one round of examination. The second round is you are looking at the buccal mucosa, the right buccal mucosa, then going on to the alveolar mucosa. When you're looking at the buccal mucosa, you can either use two mouth mirrors, but I feel it very cumbersome because the surface area of the mouth mirrors actually are on the mucosa and I'm not able to see the mucosa properly. So I usually try to reflect it with my fingers as such. So that way I go the opposite side to look at directly at that right buccal mucosa. Then for the left on the alveolar mucosa, the upper alveolar mucosa, I again like to reflect it with my fingers as such and look for these lesions. Then going to the left buccal mucosa, where you can reflect it with your fingers as such, and then go to your lower alveolar mucosa. So you have not missed any of these mucosas as such. Round 3, the same thing, but now we are focusing on the gingiva. Okay, so the buccal gingiva, the posterior side, the labial gingiva, and the anterior. then again the buccal gingiva in the posterior, and look at the lower buccal gingiva too. Then go to the lower labial gingiva, and then back to the lower buccal gingiva. So now you have not missed the gingiva as such. So that is round 3. Round 4, you ask the patient to lift their head, tilt the head so that you have a direct vision of the palatal surface as such. Okay, and then we are going to look at the lingual gingiva. You can either reflect it with 2 mirrors or use your fingers to reflect the buccal mucosa and 1 mirror to reflect the tongue, so that you have the view of the lingual mucosa as such. So then we are going to go into the other side of the lingual mucosa, the left side. The same process. You can actually reflect the buccal mucosa with your fingers and the reflect the tongue with the mouth mirror. Okay. Round 5 will be the tongue. Ask the patient to stick out the tongue. Look at the dorsal surface as such. For the lateral surface, I would love to twirl the gauze piece and hold the tongue and move the tongue to the opposite side, in whichever side you're going to see. You're going to see the right side, then move the tongue towards the left and you can have a good view there. The same goes to the left side. If you do not have a gauze piece, then the other thing you can do is ask the patient to move the tongue towards the opposite side so that you can see the left. Okay. And the end of round 5, ask the patient to lift the tongue and look at the ventral surface of the tongue as well as the floor of the mouth as such. So that's round 5. Round 6, press the tongue, ask the patient to say ah and look at the tonsillar area. So this is going to be the round 6 as such. So that's simple way of systematically looking at the oral mucosa, and this takes only 2 minutes. It's much simpler than your ICDAS or your 6-point charting as such. Okay, so thank you. Let me go on to the next. So morning was a lot of pathology and molecular pathology. Now it's going to be more of clinical. So let's start with the pre-calibration assessment. If you are all ready. So please avoid teamwork. And you can scan. So this will take you to the Google form as such. So once you have scanned, once you are in the Google form, we haven't given the participation numbers, so you can use your name as such. Please use the full name so that we will reflect it in your certificates later. Okay, another one thing I didn't tell about the certificates is you need to get about 75% and above to get your certificates. That is at the end of the 3rd assessment. You should get 75 and above. Not to worry, we'll make sure that you all reach there. Okay, all are ready. The online registered members, if you have any issues, please let us know. Online FD. Okay, all are ready? Gone into the Google form? Yes, fine. Okay. Yeah, I put a participation number. Please write your name, your full name, or whatever the name you want in the certificate. Okay, and in the next test also please do the same, write the same name so that it will be easier for us to know who is actually scored. So with that, okay, there will be 20 cases, and each case we are going to give 2 minutes, and you are allowed to ask 2 questions. I know there is a limitation when you are seeing pictures. You might want more information from the clinician, or when you are examining the patient, you are going to ask a few questions to them. So you can ask those questions. And palpation is not possible with the pictures. So if you want that information, you can ask. Okay? But 2 questions, not per person, 2 questions for all of you. Okay? So choose your questions very carefully. Okay? And I needed one volunteer to write down the questions and the answers I give. So we will look into these questions and the answers later when we are discussing this. Okay? So last humble request is please refrain from asking the diagnosis. We will discuss that later. Okay? Okay, these are going to be the choices you can see in your Google form. A is leukoplakia, B is lichen planus, C is erythroplakia, D oral submucous fibrosis, E is suspicious of cancer, F others, and I have asked here to specify. Unfortunately, you won't be able to specify in your Google form. So take note of what answer you're going to give for the others. You can write it down. Later we can discuss that. It will be very helpful coming feedbacks from you so that I can correct it if it is wrong. Okay. Then G is normal. So select one correct answer or one best answer and ensure that you are answering the correct questions. The number of the question or the case number is on the slide. So make sure you are answering the right one. Okay. So shall we start? All of you ready? Sorry? Okay. Yes. There is. So it's only normal is there, is it? Okay, sorry. Okay, there was a slight shift in the order. First is normal and then the others. It's going to be about 20 minutes. Okay, case 1. Any questions? This is case 1. Those who are online, please look at it. This is case 1. If you have any questions, you can ask. I'll be able to answer. Any questions? No questions? Habits. Okay, patient has no habits. Any other clinical information? That question I will not answer. You have to be very specific with your questions. Gender, yes. Gender, patient is a male. Age, 2 questions only, huh? Okay, I'll give that. Okay, the age of the patient is about 50 years. Is it bilateral or unilateral? Okay, the question is it bilateral or unilateral? The answer is it is bilateral. Okay, any other questions? Okay, let's go on to the case 2. This is case 2. Any questions? No questions? History. What do you want to know in history? Be more specific. Duration of the lesion. The duration of the lesion is 2 years. It has become from small to large. Yes, it started as a small lesion and it's now become large in 2 years. I mean, reached this size in 2 years. Yes? Okay, the next question is it painful? The answer is no, it is not painful. History of trauma. Good question. Yes, there was a history of trauma. Any other questions? Okay, I'm answering too many questions. Huh? I should keep it to 2. Huh? Okay, next. Case 3. Burning sensation. Is the patient having any burning sensation? The answer is no. The patient has no burning sensation. Any halitosis? No. No foul smelling, no halitosis. Is the patient anemic? It's up to you to guess. Because that has to be answered by a lab test. We are not gone into the lab still. We are looking at the clinical state. So I might not be able to answer that. Any other question? Okay, I'll restrict myself. Thank you. Okay, let's go on to the next case. Case 4. Any questions? Okay, the question is the lesion scrapable or not? The answer is the lesion is non-scrapable. Not scrapable. The lesion is not scrapable. Any other questions? Is the patient partial denture wearer? The answer is no. The patient is not wearing any partial dentures. I'll make it easy for you. Sorry? Habits. Patient is a smoker. The question is, does the patient have any habit? Patient is a smoker. Let's go on to the next case. Shall we? Okay. Case 5. I hope you can see the lesion. Duration of the lesion. The duration of the lesion is 2 days. The duration of the lesion is 2 days. Question? Pain? Yes, the lesion is very painful. The lesion is very painful. Any other questions? Is there? History of trauma? Maybe. Maybe. The answer for that is maybe. Okay, next. Case 6. Is it scrapable or not? The answer is it is not scrapable. The lesion is not scrapable. Any other questions? There's no other questions. Can we go on? Shall we go on? Okay, case 7. Any questions? Duration of the lesion is about a month. 1 month. The question is it scrapable or not scrapable? I would say it is not scrapable. Any other questions? Okay, past medical history, nil. No known medical problems. Habit, the patient was a smoker. Okay, patient was a smoker. Okay, shall we move on? Case 8. I should caution you here. Okay, the person next to you is also blind. So it might become a point where blind leads another blind. So, case 8, any questions? Duration of the lesion? Don't know. The patient came for a routine dental checkup and it was the dentist who found this lesion. The patient was not aware of the lesion, so we do not know the duration, unfortunately. You have the teeth there. I leave it to you to guess. The question was, is there a sharp tooth? You can see the teeth there. So I'll leave it to you to decide whether there was any trauma or not. Okay, let's move on. Case 9. Any questions? Okay, if there are no questions, let's go on. Case 10. Any questions? Duration of the lesion is about 2 months. Any other questions? No other questions? Let's move on. Case 11. How is it on palpation? The mucosa is the palatal mucosa. It's soft, firm in the consistency, that's it. Consistency of the mucosa. This is how many days duration? Okay, the duration is about 2 years. Is the patient a denture wearer? The answer is no. The patient is not a denture wearer. Patient is not a denture wearer. Okay, shall we move on? Case 12. Any questions? Is there burning sensation? The answer is no. The patient has no burning sensation. Restricted mouth opening? The answer is again no. No restricted mouth opening. Okay. 2 questions over. Let's go on. Case 13. Any questions? When was the restoration done? Just before taking this photograph. Very good question, but it was just taken before taking this photograph. It was done before taking this photograph. Any other question? No other question? Let's move on. Case 14. Sorry? What was the question? Sorry? Female or male patient? Okay, this is a male patient. This is a male patient. Duration of the lesion is about 6 months. 6 months is the duration of the lesion. History of? History of drug? No. No history of any intake of drug. Sorry? No. Past medical history nil. No history of drug. Okay, let's move on. Case 15. Sorry? Is it scrapable or not? The answer is it is scrapable. No, patient was not on any long-term antibiotics. Sorry? Denture, yes, patient is a denture wearer. Patient is a denture wearer. Patient does not take any antibiotics, long-term antibiotics. Can we move on? Case 16. Duration. Duration is about 3 years. Not indurated. On palpation, it was not indurated. Any other questions? Habits, beetle quichua. Habits is beetle quichua. Shall we move on? Case 17. Any questions? Any habits? The answer is no, there are no habits. Is there any burning sensation? The answer is no, there is no burning sensation. Any other questions? No? Shall we move on? Case 18. Any questions? Duration of the lesion is about 1 year. Habit, beetle quichua. Patient is a beetle quichua and the duration is about 1 year. Any other questions? Okay, no. Let's go on. Case 19. Now, this case is from Cambodia as such. Any questions? Is it scrapable or not? Yes, it is scrapable. Slightly scrapable. Sorry? No HIV. Patient is not immunocompromised. Okay, shall we move on? Okay. Case 20. Any question? Habits, very obvious, isn't it? Beetle quichua. Any other question? Okay. So if you have answered all the 20, please click submit. Do we have how many have registered and so on? Numbers. If not, I won't be able to check. If not, it's okay, fine, leave it. Yes.
How many of you are submitting? Can you please raise your hands?
So I'll just check whether I have received the numbers. And online? 30. And online, we are not sure. Okay. Around 30. Okay, fine. Okay. So with that, we end calibration assessment, pre-calibration assessment. So.
Thank you so much, sir. I'd like to call Shamala ma'am to honor our chairpersons to SPS sir and Ramesh sir. Sir, please join. Hazare sir, please join. Thank you so much for your presence, sir. Thank you.
Okay, we'll continue with the first lecture as such. It's going to be the criteria for the diagnosis of white, red, and mixed red and white lesions. We do know that oral squamous cell carcinoma can be preceded by an oral potentially malignant disorder, or it can occur in a perfectly normal oral mucosa de novo as such. So these were the terminologies. I still remember I was supposed to mark the definition for precancerous lesion and precancerous condition, and thanks to that nomenclature paper in 2005 where they unified these two. If not, we had to mark two definitions as such. So let's see, it is being changed to oral potentially malignant disorders, meaning that there are some lesions which have a higher risk of transforming to malignancy as such, but not necessarily all those lesions have to transform. So we are looking at only an oral potentially malignant disorders as such now. Okay, so that is the definition for that. Let me go on. Okay, so the issue with our OPMDs and oral cancer is it can present in different types of lesions. It can be white lesion, it can be a red lesion, it can be a mixed red and white lesion, it can be an ulcer, and it can be a swelling. So that makes for you to catch these lesions early very difficult as such. Okay, so, and we do not know which one actually transforms and which one doesn't. So you need a longer follow-up down there. And so if you have red areas or white areas and you palpate those red and white areas, please do not palpate at the center of them. Please palpate at the periphery of them. When you palpate at the periphery of them and if you find induration, and that is, if you feel the lesion firm, then you have to shift your thought process from oral potentially malignant disorders to suspicious of oral cancer. So you're looking at something very suspicious of oral cancer. So if you do not find that firmness, then probably you're looking at oral potentially malignant disorders. So the induration is something which actually indicates that the lesion is actually transforming to malignancy as such. Okay, and our oral cancers can be verrucous, or it can be a swelling, exophytic, or it can be an ulcer. I tell my students the painless ulcers are more problematic for you than painful ulcers. If there is pain, I'm happy. I know I can treat it in an easier way. But if they are painless ulcers, then alarm bells should ring, and you should send the patient to an oral surgeon for a biopsy as such. Okay, so and OSCC ulcers are usually rolled borders. They can be, and they can have indurated margins, and bleeding and fibril swellings can be. I should change this. Can you? So bleeding and fibril swellings, and pain is actually not an early sign for oral cancer. Okay, pain is not an. Okay, the pain is not an early sign of cancer. You have pain only in advanced stages. So if you're going to ask a question, is it painful? And if the lesion is not in advanced stage, the patient is going to say no. That is one of the main reasons why patients do not seek your advice in the early stages. So they are usually painless. Okay, coming to the white and red lesions. These are all the white lesions differential diagnosis you can have. It's not an exhaustive list. It's just a simple list for this workshop. Okay, we are going to look at. And leukoplakia, this definition is fantastic definition. It says what is not leukoplakia. It doesn't say what is leukoplakia as such. Okay, So your leukoplakia is a clinical diagnosis. It's not a pathological diagnosis. I will not sign a report saying that it is leukoplakia because pathology can be changed, different in. So it's only a clinical diagnosis, okay? And it is a diagnosis by exclusion. So you exclude all the previous list I've told you. Those are definable lesions. You exclude all those lesions and then come to the diagnosis of leukoplakia. So do not put your first differential diagnosis as a leukoplakia. I always tell my students, do not put that because that comes as the last after you have excluded other definable white lesions. Okay. The same goes for erythroplakia also. It is a clinical term. It is not a histopathological diagnosis as such. Okay. So let's see what are the other lesions which has to be excluded before coming to the diagnosis of leukoplakia. The next is the oral hairy leukoplakia. Okay, it's neither hairy nor it's a leukoplakia. Okay, the only thing is consistent is in the oral cavity as such. Okay, it's not. It usually is a white lesion which is present on the lateral border of the tongue. Vertical streaks you can see. Okay, and it most probably is bilateral, and it is an indication where the patient might be going from HIV status to AIDS as such. Okay, but oral hairy leukoplakia can occur in otherwise also, not necessary to be in a immunocompromised patient only. It can occur in others too. Okay, so this is, and it cannot be scraped off. Okay, this lesion cannot be scraped off as such. Okay, next come to leukodema. Leukodema falls under normal as such. It's a normal variant. Okay, you are going to have a very violaceous white lesion covering the buccal mucosa. It is very prominent in smokers, okay, and dark-skinned people as such. It's a developmental issue. It is not a true lesion. It's not a true pathology as such. So how are you going to diagnose leukodema? Clinically, you pull the buccal mucosa. If you stretch the buccal mucosa, the lesion usually disappears. Okay, and then when you release it, it reappears. If you do the same thing to oral lichen planus, it doesn't happen that way. It still stays. Okay, but leukodema, if you stretch it, it will disappear, and when you leave it back, it will reappear as such. That's one clinical, and it is not an potentially malignant disorder. Actually, no treatment required for these patients as such. Okay, coming to frictional keratosis, you should look at the cause and effect. There should be a sharp edge. It can be a broken denture, it can be a broken tooth, or it can be a broken restoration as such. That cause and effect should be there. And once you remove that, it will still stay. It might reduce a bit, but it will not completely go off. That's frictional keratosis. It's because of trauma as such. Coming to linea alba. So linea alba, again, it's a variation from the normal. Okay, it's because of the pressure effect on your buccal mucosa. Okay, you're going to see a linear line which may be scalloped. Okay, and it can be present in both the mucosas. Bilaterally, it can be present, or sometimes patients can have unilateral linea alba too. Okay, and this lesion cannot be scraped off, and it's not potentially malignant as such. It's actually a variation to the normal as such. Coming to geographic tongue, so you're going to basically see maps on the tongue, okay, and these maps keep moving, okay. So they can be mixed red and white, or it can be mostly, it's basically because of the atrophy of the papillae. So wherever the papillae are atrophied, it will be slightly red, at the margins it will be more whitish, okay. And one important thing you need to ask the patient is, does it heal? And then it goes on to another place. So that's why it is called erythema migrans. Okay, so that's geographic tongue. And the white areas, if you try to scrape, you will not be able to scrape as such. Okay, and patient might be having burning sensation because of the atrophy of the papillae. The patient will have burning sensation as such. Right. Okay, coming to pseudomembranous candidiasis. Okay, this lesion can be scraped off. Okay, this lesion can be scraped off, and it leaves a raw red area as such. Another lesion is your white coated tongue. That also can be scraped off because of food debris on the tongue. but it doesn't leave a raw red area once you scrape off. Okay, so that's the difference between white coated tongue and pseudomembranous candidiasis. But if the candidiasis is very slight, it might not leave the raw red area. So one thing you need to do is do a scraping, send the smear for the fungi as such. Okay, and these patients can be immunocompromised. They can be going from HIV positive to AIDS, or young children who are actually taking a lot of milk, they can get this. The other thing is those who are taking oral puffs, steroids, okay, they can also get this lesion. Okay, and that's about it. Let's go on to smoker's palate. Okay, the habit of smoking should be there. Okay, and this is not an oral potentially malignant disorder. It has not been considered as an oral potentially malignant disorder. You're going to have white blanched palatal mucosa as such, and tiny red spots might be there. Okay, the tiny red spots sometimes might be masked by the blanched white mucosa. That's why I put it in white lesion, but it can mostly be in the mixed red and white lesion category as such. Okay, and the red spots are inflamed openings of the minor salivary gland ducts as such. Okay, and patients should have a smoking habit, especially it's very common in pipe smokers. Okay, coming to lichen planus, there are 6 forms. Let me categorize them into 3 white and 3 red. The 3 white are the papilla, reticular, and plaque. Okay, let's talk about the white forms. The most common one is your reticular, which has networks, laces of Wickham striae crisscrossing each other on the buccal mucosa, and it is bilateral or multiple sites. Okay, sometimes it need not be bilateral, it will be multiple sites as such. Okay, so, sorry. Okay, this is your reticular type. Okay, crisscrossing striae as such. Okay, it cannot be scraped off. Okay, if you're going to pull the buccal mucosa, it will still stay. Okay. Okay. So coming to the plaque type, it's again a white type. Okay, it's going to be just like your leukoplakia. It's going to be difficult for you to differentiate between the plaque type of lichen planus and leukoplakia. Both are going to be the same. Only difference is leukoplakia usually solitary lesion. Oral lichen planus is multiple. Okay, and the plaque type is very common on the dorsal part of the tongue. Okay, mostly occurs on the dorsal part of the tongue as such. Okay, so if you are looking at a plaque type of lichen planus, please look at other places to see the reticular form or the mixed red and white form as such. Okay. And oral lichen planus, it is debatable whether it should be in OPMD or not nowadays. But let's wait for the final word from the dions as such. Okay, because there are a few people like Prof. Kamil Farah from Australia who wants to take it out of OPMD as such because there's not much of evidence. But at present, we still put it in the 2020 classification still has it in the OPMD. We will keep it there for time being. Okay. So I think the papilla type is the one I missed out. I'm sorry. The papilla type are going to have small white papules as such. Okay. And look at other places, you will see the reticular type somewhere. Okay. So that is going to give you and these patients can have burning sensation if that's mixed red and white lesion as such. Okay. If the reddish areas are the atrophied areas where they can actually have burning sensation, especially when they are taking spicy food as such. Okay, if you have seen a white lesion and it doesn't fall under any of these lesions, then you come to the diagnosis of leukoplakia. So leukoplakia is not your first diagnosis, it has to be your last diagnosis. I can't fit this lesion into anything. Then I dump it into leukoplakia as such. Okay, that's why I told you, the definition doesn't tell me what is leukoplakia, it actually tells me what is not leukoplakia as such. Okay, you have 2 types. You have the homogeneous type and the non-homogeneous type. The homogeneous type is you have a white lesion, okay, which might have some variation in the thickness. It can have a little bit variation in the thickness. Some places might be thin, some places might be thick. It might have some fragments in between, which is not very homogeneous, but still we call it as homogeneous leukoplakia, okay? And if you see this lesion, definitely you have to send the patient for a biopsy, at least at the baseline. Okay. Later on follow-up, it is up to the surgeon whether they want to go ahead with another biopsy or not. But at baseline, you should have a biopsy done for these patients. Okay. Then coming to the non-homogeneous leukoplakia, you have the nodular type and you have the speckled type, where you have, it's predominantly white and some parts of these lesions can be red. So that is erythroleukoplakia or speckled leukoplakia that falls against in the leukoplakia, not in erythroplakia. Okay, erythroplakia should be a flat red lesion, fiery red lesion. It shouldn't have any white in it. Okay, so that's why seeing erythroplakia is very rare. Okay, seeing leukoplakia or speckled leukoplakia, the non-homogeneous type is more common as such. Okay, so I told you the histopathological can vary from normal epithelium to hyperplasia, any grades of dysplasia or carcinoma in situ or invasive cancer. So, but clinically it might be leukoplakia as such. Okay, it has the homogeneous leukoplakia, they tend to have a lower potential for malignant transformation than the speckled or the non-homogeneous leukoplakia as such. And you have the proliferative verrucous leukoplakia. Okay, coming to the quid-related lesions here, this is a Chewers mucosa. Okay, these patients are having the areca chewing habit as such. Okay, but this is not an OPMD. It is not classified as OPMD. The patient's mouth opening is still not limited. Okay, this is, we can't say this is previous stage to oral submucous fibrosis also. Okay, because we do not know the transformation rate of Chewers mucosa to oral submucous fibrosis. That's something interesting. You can actually look at a study for that. So here, the patient is going to have reddish or brick red color fragments of the quid stuck to the mucosa as such. And if you just run your probe or your mouth mirror, the epithelium is sort of very fragile. It can actually peel off there. Okay, and it's mainly in places where the patient actually keeps the quid. Okay, then keep the quid for a long time and chew on it, so the fragments can actually get stuck into the mucosa as such. This is called Chewers mucosa. Coming to the oral submucous fibrosis, here oral submucous fibrosis, as already there's been a lot of talk today morning, I need not really elaborate on it. Let's go into the clinical part alone. We're going to have a blanched mucosa, okay? And the other thing is limited mouth opening. And when you palpate the mucosa, you're going to look at fibrotic bands which are actually running from upper buccal sulcus to the lower buccal sulcus. Okay, so that is your oral submucous fibrosis. It can affect the buccal mucosa, then later on it affects the restriction in tongue movement as well as the uvula movement. You can have the hockey stick uvula and so on. Okay, that's oral submucous fibrosis. Coming to our hero of today is for us to diagnose this lesion as early as possible, the neoplastic lesion. It can be white. I told you, if it is white lesion, please palpate the periphery of the lesion to see whether it is indurated or not. If there's, sorry?
Hero or villain?
For us, he should be a hero so that we can catch him as early as possible. Okay, so if we can catch this lesion as early as possible, that makes a big difference for the patient as such. Okay, and if you are looking at this lesion, and if there is on palpation there is induration, then please send the patient for a biopsy as such. Okay, your main point here is induration again. So if you are looking at induration, your diagnosis should shift from OPMDs to suspicious of oral lesion. Okay, coming to the red lesions, these are all the red lesions. Let's go one by one. Okay, again, erythroplakia should come at the end as such. Okay, it's a clinical term. Important thing to differentiate between erythroplakia and erythroleukoplakia is erythroleukoplakia will have some white. Erythroplakia shouldn't have any white. It should be again flat, cannot be raised. Okay, so these are the two things you need to look at. Okay, and again, oral cancer, no need to stress, it's going to be indurated as such. Okay, so you have certain lesions which can mimic oral lichen planus, and discoid lupus erythematosus is one of that. Okay, it's going to be similar to oral lichen planus, very common in the lip. Okay, and the center part is going to be reddish. Okay, whereas periphery, if you want a proper diagnosis of it, biopsy is the only way to do that. Okay. Okay, coming to the red types of lichen planus, you have the atrophic, erosive, and bullous type. The atrophic type, you are going to have reddish, and erosive is going to be ulcerated as such. Okay, so you're going to have reddish lesion. Look at the periphery of the red lesion. That's why you can go see the striae. Okay, if it's just red lesion and you don't see the striae, you cannot diagnose oral lichen planus as such. Okay, so the atrophic type, where you can actually have an atrophy of the tongue, and look at again the periphery of the lesion where you can see the white papules or the striae as such, and they cannot be scraped off. You have the erosive type where you can actually see a central ulcer, and around the ulcer you're going to see reddish area, and just beyond that red area again you look very carefully, you can see the white areas as such, and they are going to be bilateral or multiple sites. Okay. So erythematous candidiasis, again red lesion, but multifocal red lesion. Usually it can occur on the tongue, and since it occurs on the tongue is always touching the palate. The palate also can have this lesion as such. Okay. So median rhomboid glossitis, I think the term nowadays is something else. What is it? Candidiasis associated erythematous lesion or something. Okay, I have not updated myself, so I'll still call it as median rhomboid glossitis here. Okay, so you have atrophy of the papillae at the junction between the 2/3, anterior 2/3 and posterior 1/3 of the tongue as such. So it's going to be very reddish, and atrophy of this one you're going to have as such. Okay, denture stomatitis, there should be a denture. Okay, it's usually long-standing denture. Okay, and this is again a erythematous candidiasis. The patient is actually going to wear the denture for a longer time, not remove the denture as such. Okay, and you're going to have a red area just at the denture surface only. Okay, angular cheilitis, the patient is going to have breaks in the ulcers on the corner of the mouth, and this can be because of either your vertical dimension is lesser. Okay, one thing I don't like about prosthodontists is asking me to do that vertical dimension, but I know what is the consequence if you don't do it. Okay, because of the pooling of the saliva, and a very good medium for the bacteria as well as fungal to actually grow there is usually a mixed lesion. Okay, it's bacterial plus fungal as such, and you can have fissuring and scaling in the corner of the mouth. So these are my references. I'll just finish the first lecture. Let me go on to the second lecture. So it's more of a crash course of oral medicine, which I'm taking. Okay, next lecture is on the criteria of pigmented lesions, ulcers, and swellings. Let's go on to the pigmented lesion. 3 questions I would like to ask when I see the pigmented lesion. Okay, what is the color of the pigmented lesion? Is it brown, black, or reddish purplish color? Okay. Then is it a solitary lesion or a diffuse multiple lesion? Okay, that's the second question I would into. And is it from the pigment is from our body or is it coming from outside the body? Okay. So if you have these three things answered, you can actually figure out which lesion it is as such. Okay. So the endogenous pigments and the exogenous pigments, let's go on. Okay. I will divide this into focal lesions and diffuse and bilateral lesions. In diffuse and bilateral lesions, it can be early onset or predominantly adult onset. In focal lesions, according to the color. Okay, let's see the diffuse and bilateral lesions as such. Early onset can be physiologic pigmentation and Peutz-Jeghers syndrome. Predominantly adult onset, again, divide into whether you have systemic signs and symptoms or not. If you have systemic signs and symptoms, it can be Addison's disease, heavy metal pigmentation, or Kaposi sarcoma. If it doesn't have any signs and symptoms, systemic signs and symptoms, it can be drug-induced pigmentation, post-inflammatory pigmentation, or smoker's melanosis. Okay, coming to the focal, again, according to the color, if it's red, purple, or blue, then I will do a diascopic test. I'll press the lesion and see. Okay. If the lesion blanches, then it comes into hemangioma varix. If it does not blanch, then it can be thrombus or hematoma as such. So blue-gray, it can be amalgam tattoo or it can be graphite tattoo in some cases, and blue nevus. If it is brown and black, it can be melanotic macule, pigmented nevus, melanoacanthoma, or melanoma. So let's see. Okay, coming to racial pigmentation. So usually it affects the attached gingiva. Okay, usually the racial pigmentation seen in dark-skinned people in the attached gingiva or in the area of trauma. Okay, especially the tip of the tongue and so on. So those are the sites. Sometimes in palate you can see its prominent areas of friction you can see more, and it becomes intense with aging as such. So that is racial pigmentation. If you're seeing multiple melanotic macules around the oral cavity, then you are looking at Peutz-Jeghers syndrome, it's especially in the lips, perioral tissues, or in the distal fingers and toes, you're going to see a lot of these melanotic macules as such. Okay. So next is Addison's disease. Here you are going to have more of a browning effect on the skin. Okay. As well as in the mucosa, you can have the melanosis patch. Apart from this, the patient might have hypoglycemia and hypotension. Okay, those are associated features you might need to look at and ask about the past medical history for these patients. Take a thorough past medical history. Okay. Coming to heavy metal pigmentation, these are metals which can cause, and especially those people who are working in paint industry can get this. And here you're going to have a linear pigmentation of the around the marginal gingiva is where you're going to get the linear pigmentation as such. Kaposi sarcoma, there are three forms. The classic Kaposi sarcoma, the endemic, as the AIDS associated. In this part of the world, it's mostly the AIDS associated Kaposi sarcoma is what you're going to look at. And the lesions can be on the oral mucosa, palate, tongue, lip, and buccal mucosa. So they usually start as a flat macule. Okay, it usually starts at a flat macule and then slightly raises to become a plaque and then becomes a nodular lesion as such. And it's reddish to purplish in color. Okay, so you can see the macule and a slightly raised plaque and more nodular lesion as such. So that's Kaposi sarcoma for you. Then drug-induced pigmentation. This is one of the difficult lesions which you're going to diagnose because it's going to be basically based on your drug history as such. Okay, and these are all the drugs which can cause. And there is the mechanisms which I have put. I'm not going to go into that. Okay. Coming to the post-inflammatory pigmentation, this one you can actually see in patients who are having waxing and waning of the oral lichen planus. Okay. Oral lichen planus is not a steady lesion. It waxes and wanes. Suddenly the patient will come with a lot of lesions, and then after some few days it goes back, or few months it goes back. So it waxes and wanes, especially the reddish lesions when they heal. That's at the background you are going to get pigmentation. And the foreground, you will see the white lesions, white striae and so on. Okay? So foreground, you are going to see the white lesions. At the background of that, you will see the pigmented lesion. That's post-inflammatory pigmentation as such. Okay. One of the toughest to diagnose if you are in India, because most of us are going to have facial pigmentation. And if the patient is a smoker, so most probably has both. It's very difficult to distinguish. If I'm looking at Chinese patients in Malaysia, I know that the patient has pigmentation. I can definitely ask the patient whether they are smokers, and I can diagnose smoke. But in India, it's going to be very difficult because we have facial pigmentation. But if the patient is a smoker, then most probably you're having both together as such. Okay, so that's how they look. Okay, this is more on a white skin patient where it actually is a very focal lesion. Whereas in a dark skin patient, it's usually a more diffuse lesion as such. Okay, coming to the hairy tongue. Okay, this can be because of various factors. Okay, there is hypertrophy of the papillae, and your food substance are going to get stuck in it, and your coloring food substance are going to make it black or brown as such. Okay, so if your chromogenic bacteria is actually colonized there, it's going to be very black as such. Okay, so these are all the precipitating factors for hairy tongue. And the coloring effect can come from your food, tobacco, coffee, tea, and other food, or from the chromogenic bacteria as such. Okay, coming to hemangiomas, these are focal lesions, again reddish to purplish in color. Okay, and the test you're going to do is you have to do a pressure test, diascopic test. You can take either a glass slide or your plastic instrument and just press on the lesion, it will blanch. The reason is the blood vessels are still there, okay, and you're pushing the blood within the blood vessels. Such. So that is the clinical examination you can do for hemangiomas. So that's a diascopic test down showing there, okay. Lingual varicosities, it's basically because of aging, okay. It's again like your varicose veins, but under the tongue as such. And these also, if you press, they will blanch as such. Okay, varix, again, a pinpoint area where you have proliferation of the blood vessels. Okay, if you're going to press these lesions, they will blanch as such. Okay, this is amalgam tattoo. Okay, here the patient should be having a large restoration of amalgam, which is actually rubbing on the mucosa for a long time. So some part of the amalgam actually transfers into the mucosa and gets stuck into the mucosa. So that's how you get the amalgam tattoo as such, embedding of the amalgam fragments. Okay, coming to oral melanotic macule, focal lesion, symmetrical lesion, okay, less than 5 to 6 millimeters in size, okay, and so they can be on the vermilion border of the lip, gingiva. If that melanotic macule is slightly raised, then you're going to think about nevus as such, isn't it? Okay, so if these melanotic macule or nevus actually has these variations, asymmetry or border irregularity, color variation, and the size in more than 6 millimeters, you're going to think about malignant melanoma as such. Okay, and it's very common in the gingiva as well as the hard palate. So that's about pigmented lesions. Let's go on to ulcerative lesions. In pigmented lesions, I told you 3 things. That is whether it's focal or diffuse, then the color, then I'm looking at the exogenous or endogenous. Here I'm looking at single or multiple lesions, acute or chronic lesions, primary or recurrent lesions as such. Single oral ulcers, acute, I'm very happy to see them. They'll have pain. Okay, if they have pain, I'm very, very happy. Okay, because they could be because of trauma, your traumatic ulcer. That should be a cause and effect. But unfortunately, many of the patients might not be able to tell you that whether they had a trauma or not. Okay, so keep that in mind. Huh? But these ulcers will be very painful. Okay. Okay, site can be tongue, buccal mucosa, lips. It will be single, painful, with an erythematous area around. Okay, and it heals usually. If you remove the cause, it will heal within a week or two. Okay, the rule of 2 weeks, according to the UK guidelines, is 3 weeks, but Asian guidelines we follow 2 weeks. So review the patient after 2 weeks after you remove the trauma. If the lesion actually heals, then it's most probably traumatic. If it doesn't heal, it requires an immediate biopsy as such. In UK, they are following 3 weeks. I follow 2 weeks, but in UK, they are following 3 weeks as such. Okay, coming to, it's been quite some time. I think from 2015 or so, they are following that. Okay, coming to single oral ulcers, it's chronic. Looking at chronic ulcers, these ulcers are not going to have much of pain. If the ulcers do not have pain, alarm bells should ring in your. So because you have to further investigate them, send them for a biopsy immediately. Okay, painful ulcers are usually fine with me, but painless ulcers are more sinister. Okay, so you can have tuberculous ulcers usually on the dorsal part of the tongue with undermined margins, and painless irregular ulcers with thin undermined borders, usually in the dorsal part of the tongue, palate, buccal mucosa, and lip. Coming to syphilis, each stage of syphilis has ulcers. The primary stage has cankers, no pain at all. The site where the Treponema pallidum actually entered, they will have ulcers, and there will not be any pain there. Okay, the secondary syphilis, you can have mucus patches as well as mucus ulcers. These are called as snail track ulcers. And tertiary syphilis will have more of a granulomatous ulcer, the gamma. It's again pain-free ulcers, nodular lesions in the hard palate and tongue, which are more slightly blackish. So that's a canker. Okay. Again, coming to oral squamous cell carcinoma, it can present as ulcers. Again, please palpate the margin of the ulcers, not at the center of the ulcer, margin of the ulcer, to see whether it is indurated or not. Another thing is they will not have pain. Okay, again, neoplastic ulcers, early stage will not have pain, advanced stage will have pain. Okay, coming to recurring oral ulcers, these are multiple ulcers, small ulcers, recurrent abscess minus, a very, you have a fibrinous bed, yellowish bed with an red halo as such. These are very painful ulcers. Okay, coming to recurrent abscess major, very severe pain will be there. Okay, coming to recurrent abscess minor, there will be multiple, it can be multiple. Recurrent abscess major also multiple, but the numbers are much lesser. Okay, you might have 2 or 3 ulcers at a time. And you'll have again, these can be a little deeper ulcers and more painful as such, and a reddish halo around them. Okay, so coming to herpes labialis, again multiple ulcers, bloody crusting will be there present, and the patient might have prodromal symptoms as such. And recurrent herpes infections usually occurs in the keratinized mucosa, okay, that is in the palate and the gingiva as such. You have multiple small ulcers, smaller than your minor ulcers, but they coalesce together to form a larger ulcer as such. Okay, so acute multiple ulcers, again the cause can be HSV1. They will have prodromal symptoms, and it will occur in the gingiva, buccal mucosa, tongue. So usually in young kids, they can have this, and you can see a very erythematous gingiva as such, and ulcers around in the mouth. Okay, primary herpetic gingivostomatitis, this occurs in the keratinized mucosa again with prodromal symptoms. Herpangina, These ulcers are at the oropharyngeal region, back of the mouth, okay, and multiple smaller ulcers can be present. Okay, herpes zoster, these ulcers will not cross the midline and they will be present at one dermatome as such. Okay. Erythema multiforme can be because of drug or can be because of virus. Okay, if it is there is a drug history, it's an acute condition. When they take the first dose of drug or the second dose of drug, they get these lesions as such. And I've seen for paracetamol, mefenamic acid, ibuprofen, all these NSAIDs actually causing this, and they can develop target lesions on the skin. Multiple chronic multiple ulcers, your vesiculobullous lesions all fall under this. Okay, you're going to have multiple ulcers which are present for a long time as such. And pain will be there, but the pain will be of milder type, not very severe pain as such. Okay, you'll have vesicles and bullae which burst and ulcerate as such. And in mucous membrane pemphigoid, apart from the oral ulcers, the eyes also can get affected as such. Okay, buccal mucosa involvement as well as eye involvement. Okay, desquamative gingivitis is not an diagnosis by itself. It's actually a clinical finding which can be present in many conditions like your oral lichen planus or your pemphigus vulgaris or mucous membrane pemphigoid. So do not look into desquamative gingivitis as a diagnosis. Don't put it as a diagnosis as such. Okay, angular cheilitis, I've already talked to you about this, and it can be because of deficiency too. Okay, coming to erosive lichen planus, already talked. Let me just go off this, and you have the exophytic lesions, the lumps and bumps, the last ones. Okay, here we are seeing pyogenic granuloma, which is more reddish in color. It easily bleeds. It's usually in the gingiva. It's a sessile or pedunculated lesion as such. Okay. It can also occur in other parts of the oral cavity like tongue, lip, and buccal mucosa and palate. Okay. So the difference between pyogenic granuloma and your focal fibrous hyperplasia is focal fibrous hyperplasia, the mucosa, it will be of the normal oral mucosal color, whereas your pyogenic granuloma will be more reddish in color. Okay. The mucocele, a dome-shaped swelling, bluish in color, most common in the lower lip as such. Okay. And ranula, mucocele on the floor of the mouth, which has, which actually raises the tongue as such, and it will also be fluctuant as well as transillumination is positive here. Okay. Coming to oral squamous cell carcinoma, again, it can be a fungating exophytic mass. Again, induration will be present here. Okay, and verrucous carcinoma looks very large, okay, very whitish, thrown into folds. Okay, with that, I finish my second lecture. Let's go on to the third one. This is going to be a recap of the first one. Okay, these are the lesions we are going to look at, potentially malignant disorders and non-potentially malignant disorders. The differential diagnosis for this is lichen planus, pseudomembranous candidiasis, and leukoplakia. So what are the questions you're going to ask me? Yeah. Sorry? Is it scrapable or not? Okay, if it is not scrapable, then you are going to think about lichen planus or leukoplakia. But if it is scrapable, you're going to think about pseudomembranous candidiasis as such, isn't it? Okay. So this lesion is pseudomembranous candidiasis because it can be rubbed off. Okay. Coming to the differential diagnosis of lichen planus, pseudomembranous candidiasis, geographic tongue, hairy leukoplakia, and leukoplakia. So what would be your question here? Again, first, scrapable or not. If it is not scrapable, you're going to take off pseudomembranous candidiasis. Okay. If it is scrapable, you're going to take off, it is going to be pseudomembranous candidiasis. Not scrapable, the other lesions come to the. So for lichen planus, it should be bilateral or multiple sides, and then you're going to have striae as such. Okay. For geographic tongue, this definitely cannot be geographic tongue because it is in the lateral border as well as the ventral surface of the tongue. Usually geographic tongue is in the dorsal surface as such. Okay. Hairy leukoplakia can, but usually it has vertical white streaks bilateral. Okay. So we have taken off all. So we come to the diagnosis of lichen planus as such. Okay. Sorry, leukoplakia as such. Sorry. Then coming to this lesion, could it be erythematous candidiasis? Okay, for erythematous candidiasis, we are not going to look at whether it's scrapable or not. Huh? Okay, it's only the pseudomembranous we are looking at. Okay. Erythematous candidiasis, you might associate with dentures, or it might be on the dorsal part of the tongue, like median rhomboid glossitis or angular cheilitis and so on. But this lesion doesn't fit into that. Okay, can it be lichen planus? Yes, papillary type can be like this. But look at the periphery, I don't see any striae as such. Okay, so it falls under leukoplakia. Okay, coming to this lesion, ask for whether it is bilateral or multiple sides. If it is yes, then you're looking at reticular type of lichen planus. Okay. Coming to, again, this, you have the reddish area and peripheral striae. So, and if it is bilateral, then you're looking at lichen planus as such. Okay. So you have a diffuse blanched area on the palate with red spots. It's going to be smoker's palate. Okay. Here, okay, what is the clinical, so you're going to stress the mucosa and see if it disappears, then it is most probably leukedema. Okay, so you can see maps on the tongue. So it's going to be geographic tongue, fine. Okay, and it is also going to migrate from one place to another. Okay, so here you have vertical streaks on the lateral part of the tongue. Okay, patient might be immunocompromised here, going from HIV to AIDS as such. Okay. This lesion, can it be lichen planus? I don't see the peripheral striae. Okay, can it be candidiasis? Possible, but usually candidiasis, erythematous candidiasis is multifocal, not one single lesion. Okay, geographic tongue, it's not on the tongue. Oral cancer can, but induration. Okay, ask for induration. Speckled leukoplakia, there's no white lesion, it's only red lesion, red flat lesion, so it falls under erythroplakia as such. Okay, so here you see multiple red spots. Okay, so that is an indication for erythematous candidiasis as such. Okay, if the patient is a denture wearer, and you can see it's a denture stomatitis as such. Okay, so I'll just skip these. It's just that induration is so important here to differentiate between your lesions. Let's go on to the next one. Okay, your differential diagnosis here can be smoker's melanosis, Addison's disease, oral melanotic macule, pigmented nevus, melanoma. Okay, so this is a very generalized lesion. Okay, a diffuse lesion on the gingiva. So I wouldn't go into Addison's disease, oral melanotic macule, pigmented nevus, melanoma, or heavy. It's most probably is a smoker's melanosis or racial pigmentation. Okay, if the patient has smoking habit, then it can be smoker's melanosis. If the patient doesn't have smoking habit, then it is racial pigmentation as such. Okay, so let's go on. Sorry. So these can be the differential diagnosis for this lesion, but you're looking at if it is a bluish dome-shaped swelling on the lower lip, it can be mucocele. But be very careful. Mucocele, I have many cases where I have diagnosed mucocele, clinically mucocele, but histopathologically from lymphoma to other lesions as such. Okay. So always take a photo of your mucocele. You cut the lesion, send to the histopathologist. If it comes as mucocele, you delete the photo. If it comes as something else, keep the photo. Okay, it might be a good case report as such. Okay, very common in the a dome-shaped swelling in the floor of the mouth. Okay, lifting the tongue, transimulation and fluctuation. It's ranula. Okay, here the patient is going to have severe pain. Okay, and an acute single ulcer. Okay, that can fall into traumatic ulcer. If it is a chronic single ulcer, then you are looking at infection or neoplastic lesion. Okay, with no pain as such. Okay. Okay, these are small ulcers. Okay, and these can be if they are recurrent, then look at systemic lesions. Okay, if there are systemic lesions, then it can be Behçet syndrome or cyclic neutropenia. If it is no, then ask for fever. If there is fever, then it can be periodic fever aphtha. Or when there is no fever, then you are going into recurrent abscess stomatitis as such. Okay, the very common lesion of herpetic ulcer here. Okay, herpes labialis, and look at traumatic cause or not. Okay, if there is no, then primary and secondary syphilis will not have pain, but herpes labialis is going to have pain as such. Okay, erythema multiforme might be similar, but usually erythema multiforme is more generalized, and whereas herpes labialis is only in the lip area. Okay, this is herpes zoster. Usually herpes zoster do not cross the midline as such. Okay, with that, we finish the fourth one. Okay, back to your assessment. Okay, are you guys ready? I know it's a bit of a crash course on oral medicine. So let's start the calibration assessment 1. This is the last one for today. Huh? Okay, please scan. And please write your name. Make sure your name is the same as what you wrote the last time. For 35 more. Okay, ready? Shall we start? Okay. 20 cases, 2 minutes, 2 questions. Okay, this you guys know now, by now. So let's go on to, okay, case 1. I need someone to write the questions. Is it possible? Okay, any questions? What? Okay, the question is unilateral or bilateral. The answer is it is bilateral. Unilateral or bilateral, the answer is it's bilateral. Any other questions? No other questions? Okay, let's go on to, I give you some time. Okay. Case 2. Any questions? Sorry? Induration, the answer is no, there is no induration. Duration of the ulcer, it's about 3 days. Sorry? Is it painful or not? The answer is yes, it is painful. The duration is 3 days. Okay, it is a painful ulcer. Can you just take down the questions along? For case 2, the case 1, they asked the question, is it unilateral or bilateral? The answer was unilateral. Case 2, sorry, bilateral, sorry. And then the question, case 2, the question was, first was, is there induration? The answer is no. Is it painful? The answer is yes. And duration is 3 days. Okay, case 3. Duration is 1 month. Habit history smoker. Any other question? Any question? Is he a denture wearer? The answer is no, not a denture wearer. Any other question? No other question. Okay, let's move on. Case 4. Duration of the lesion is about 2 years. Any other question? Is it painful? The answer is slight burning sensation. Not pain, but very slight burning sensation. Does it appear and disappear in the last 2 years? No. It does not disappear. Was it progressive or as same size? I would say it's the same size. Any other question? Habit, patient is a smoker. Okay, let's move on. Case 5. Burning sensation, no burning sensation. Habit history, no habit history. On palpation is soft. On palpation it is soft. Any other questions? No other questions? Let's move on. Case 6. Question? Habits. Patient is a beetle quid chewer. Burning sensation, maybe slight burning sensation. On palpation, soft. Any other question? No other question? Duration about 3 years. Duration is 3 years. Okay, let's go on. Case 7. Is it scrapable? The answer is yes, it is scrapable. Is the patient denture wearer? No, patient is not a denture wearer. Any other questions? Okay. Let's move on. Case 8. Duration of the lesion is about 2 years duration. Habit history, patient is a smoker. No burning sensation, no pain. Induration, no induration. Any other question? It was an incidental finding, but the patient knew that it was there for 2 years. Patient didn't seek treatment for this as such. Okay. Case 9. You want to go back to case 8? Okay. Case 9. Any questions? Any questions? Patient's complaint. Patient came for a routine dental checkup. Any questions? Other questions? No? Incidental finding of what? Maybe? Okay, let's go on to the next one. Case 10. Is it scrapable or not? It is not scrapable. Habit, no habits. Duration about 3 years. No habits, duration is 3 years, not scrapable. Sharp tooth trauma, no. No sharp tooth, no trauma. Medical history, no medical history, no known medical problems. Any other question? Okay. So, case 11. Question? Okay, they migrate. Burning sensation, yes. Okay, they migrate and they have burning sensation. Okay, case 12. Habit history, no habits. Sorry? Induration, no induration. No induration, no habits. Trauma, no trauma history. Sharp tooth, this is only trauma, no. Pain, no pain. Duration is 5 years. It's progressing slightly, but it started a small lesion. In 5 years, it's become this lesion. Okay? Shall we move on? Sometimes you ask more questions, you get confused. Case 13. Is it scrapable or not? The answer is no, it is not scrapable. Any other question? Any other question? Okay, it is bilateral lesion. The question is it bilateral? The answer is yes, it is bilateral. Okay, let's go on to case 14. Trauma, no, there's no trauma. Not that the patient knows of. Lower anteriors, I'm looking at it. Maybe sharp. Pain, no pain. Okay, I'll make it easy for you guys. Trauma, yes. Duration is about 6 months. Okay. Case 15. Is it bilateral? The answer is yes, it is bilateral. Any other question? No. Okay. Case 16. Is it scrapable? The answer is yes, slightly scrapable. It's slightly scrapable. And doesn't leave a raw red area. Okay. Next question. Case 17. Burning sensation, the answer is no. There's no burning sensation. Habit history, obvious. Beetle quit chewer. It is up to you to decide. The question is which lesion I should focus. It's up to you to decide. That's a rather good question, but I'll leave it to you to decide. Okay, shall we move on? Okay. Case 18. Bilateral, yes. Habit, beetle quit chewer. On palpation, yes, fibrotic bands. Yes, limited mouth opening. Case 19. History. What do you want in history? Patient complaint. Patient came for ortho treatment. Okay, can we move on? Okay. Case 20. Habits, obvious. Beetle quit chewer. Any other question? No other question? Okay, let's move on. That's the end. Please submit. Okay, let's see for tomorrow. Today we end with this. Tomorrow we will discuss the results of calibration assessment. Okay, thank you very much.
லேப்டாப் மட்டும் எடுத்துகிட்டு போகிறேன் வேலை இருக்கிறதுல இதெல்லாம் அப்படியே வச்சு மூடிட்டு இருந்தேன் இல்லை இல்லை அதில் இப்போ ரெக்கார்டிங்லாம் போட்டல போயிட்டு க்ளவுடில் அப்லோட் பண்ணிடலாம் நாளைக்கு போயிட்டு அப்லோட் ஊருக்கு சரி ஒரு அப்லோட் பண்ணி சொல்கிறேன் இல்லை பென்ட்ரைவ் சரிங்களா காப்பி பண்ணி கொடுப்பேன் ஃப்ரெண்ட்ஸ் சார் அனுப்பி விட்றேன் கொஞ்ச நேரம் தான் எவ்வளோ காலையிலேருந்து கேட்கு சரியில்லை இல்லைனா பென்ட்ரைவ் கொடுங்க நான் வீட்டில் காப்பி பண்ணிவிட்டு அது இருக்கா அப்போ வேண்டாம் இல்லைனா நான் நாளைக்கு காப்பி பண்ணேன் நாளைக்கு என்ன பண்ணுங்க பென்ட்ரைவ் காலையில் என்னென்னு கொடுத்துருங்க பரவாயில்ல கொடுங்க இன்னைக்கு எதோ நாளைக்கு காப்பி பண்ணிடுறேன் நாளைக்கு போகும்போது காப்பி இதில் இதில் தான் இதில் கிடையாது இதுக்கு அடுத்த மாடலில் தான் ரெக்கார்டு இது நான் வாங்கினது 35 இதுக்கு அடுத்த மாடல் 45 அதுதான் 50 45 அதை மாற்றிட்டேன் நான் என்ன பண்ணிட்டேன் இது வந்து ஜஸ்ட்டு ஒரே ஒரு ஆப்ஷன் மட்டும் ரெக்கார்டிங் மட்டும் எனக்கு பண்ணிட்டேன் பார்த்தா இதில் ரெக்கார்டிங்கும் கிடையாது மல்டிவியும் கிடையாது HDMI இருக்குது HDMI எனக்கு எல்லாமே எஃபெக்ட் எல்லாமே HDMI FD வாங்கினீங்கன்னா இப்போதைக்கு அப்ரிவேஷன் அது வாங்கினீங்கன்னா எல்லாத்தையும் கன்வெர்ட் வாங்குற மாதிரி இந்த இது வாங்கணும் எத்தனை வாங்குறோமோ அத்தனை வாங்குற மாதிரி ரெண்டு மாடல் இருக்குது SDI டிரான்ஸ்லேட் HDMI அதில் எஸ்டிஐயில் என்ன அட்வான்டேஜ்னா ரெண்டு அவுட் எடுத்துக்கலாம் ஓவரான அவுட் எடுக்கலாம் இது ஒரு அவுட் எடுக்கலாம் பிளாக் மேஜிக் அது பிளாக் மேஜிக் தான் நீங்கள் தானே கேட்குறீங்க 50,000 பிளாக் மேஜிக் காமன் இதில் வந்து ரெக்கார்டிங் எத்தனை கேமரா மேக் பண்ணுறீங்க அத்தனை கேமரா ரெக்கார்டிங் மிக்ஸ் பண்ணுறீங்களா அவுட்டு இந்த அவுட்டு தனியாக கொடுத்துருங்க 3 கேமரா போட்டிங்கன்னா 4 ரெக்கார்டிங் $500 இல்லை நம்ம இந்தியன் மணியில் தான் பார்க்கணும் இந்த கேமராலாம் ஃபேஸில் இருக்கிற சொல்லி போனால் 10,000 செக்ஷன் ஒரு நாளைக்கு அதுக்கெல்லாம் அவங்களாம் கொடுப்பாங்க பட் அதை பேசிட்டு இருக்காங்க எத்தனை போட்டிருக்கு இது 12 தான் போட்டிருக்கு 12 இன்ட்டு 24 24 அவுட் இருக்கும் பின்னாடி எத்தனை அவுட் 24 கஸ்டமைஸ் சிஎம் ப்ரோக்ராம் எங்கே அவுட் எடுக்கிறாங்க இந்த நேரத்தில் உதயநிதி நான் அவுட் எடுத்தேன் சேனல் அவுட் எடுத்தேன் ஸ்பீக்கர் போகிற மாதிரி வச்சுட்டு போவேன் வீடியோ தான் நான் சொல்கிறேன்.
Thank you very much for listening to us. So, sir's session is not yet over. So today it's only the first half. Tomorrow will be the evaluation of the calibration and the pre-calibration. So it continues tomorrow as well. So I'm hoping to see you all tomorrow also. So but today's session has come to an end for today. Thank you very much for attending. Thank you. Thank you, sir, for coming all the way.